Today we have sessions on body box, CPET, diaphragmatic function testing, 6 minutes walk test, and FENO, followed by hands-on sessions. I hope it's a day of learning and further enriching of our knowledge. I'd like to call Dr. Nagarjuna to just brief about the second day.
Good morning, everyone. So welcome to day 2 of our PFT Summit, and it is really heartening to see people on a Sunday morning at 9:10. I'm sure more people will join as the sessions start. So yesterday was a very interactive learning day for every one of us, so where we spoke about spirometry, oscillometry, and DLCO. Today we will cover what has not been covered yesterday. So we will talk about lung volumes, we'll talk about exercise testing, both 6-minute walk test and the conventional cardiopulmonary exercise testing. We'll also discuss about FENO and a little bit about muscle function assessment. So how to assess the function of diaphragm. So we have again very good experts from across the country. So just like yesterday, the first half of the day will be sort of lectures and case-based interpretations, and followed by hands-on in the afternoon. The only difference is that today afternoon the hands-on won't be in the 5th floor, it will be in the 2nd floor, where we'll be opening our PFT center at 12 o'clock. So also for people who want to have more hands-on on yesterday's equipment, so we also have the PFT DLC oscillometry stations here. So if anyone wants to again redo the test, they're more than welcome to go and have a feel of the equipments which were shown yesterday. So I think with this we will not waste much time. We would want to stick to the schedule. So we will start off the session on lung volume assessment. Thank you.
Thank you, sir. So we begin our first session on box-plethysmography. I'd like to invite the moderators for this session. I would like to invite Dr. Gangadhar Reddy, sir. He is the head, HOD and senior consultant and interventional pulmonologist at Department of Pulmonary Medicine, Yashoda Hospital, Secunderabad. Sir is a former assistant professor of Osmania Medical College and also has been a professor at MNR Medical College. I would like to invite the second moderator for the session, Dr. Richa Gupta. Madam is professor and head of Department of Respiratory Medicine at CMC Vellore, has over 50 publications and has special interest in chest ultrasound, pleural diseases, and medical thoracoscopy. I would like the moderators to invite the speakers and initiate the session. Thank you.
Good morning. At the outset, I am very much thankful to Dr. Nagarjuna and his team for inviting me to chair this session. Good morning, one and all. So yesterday I have learned many things about PFT, especially basic spirometry, DLCO, and other things. Today we will be going to listen more about lung volumes, which are more precise than the routine spirometry. For this, we have Dr. Pradeep Prasad, who is the, I can say, upcoming pulmonologist, very dynamic pulmonologist of Yashoda Hospital, who is MBBS, DNB, and MRCP, who also has got a fellowship in interventional pulmonology. So would be very pleased to hear from him. Dr. Pradeep Prasad, please.
Thank you, sir. Good morning to one and all. So today I'll be talking about lung volume assessment, the physiology, method, and the technical standards. I have a very daunting task in front of me to speak before Deepak Talwar sir introduce the topic, before sir comes and takes over the interpretation. So I'll try to do my best to simplify this topic. Basically, as we know, spirometry is a dynamic lung function test which can only measure the lung volumes which are inspired and expired out. It cannot measure the volume of the lungs, volume remaining inside the lungs after a complete expiration. So this is a difficult graph you see, where among the 4 lung volumes, that is the inspiratory reserve volume, the tidal volume, the expiratory reserve volume, and the reserve volume and the residual volume, the spirometry cannot measure the residual volume, and hence it cannot measure 2 capacities, that is the functional residual capacity and the total lung capacity. So just to define these volumes before we go further, the residual volume, or the RV, is the volume of the gas remaining in the lungs at the end of a maximal expiration. The functional residual capacity is the volume of the gas remaining in the lungs at the end of a quiet breath. The thoracic gas volume, or the VTG, is the absolute volume of the gas in thorax at any point in time. And the total lung capacity is the volume of the gas contained in the lungs at maximal inspiration. So, from 1680, researchers have been interested in the volume of the lung that is remaining after a maximal expiration. Corns and Borelli were the first scientists that suggested that the lung still contained air after a maximal expiration. At the turn of the 19th century, H. Davy was the first person to measure his reserve volume using a hydrogen-containing mixture. This was further refined in 1864 by Nestor Grehant, where he measured the FRC using a similar technique. In 1940, Darling, Cournard, and Richards proposed the open-circuit nitrogen washout method. And then 1941, the hydrogen was replaced by helium in the gas dilution technique. In 1956, Dubois proposed the body plethysmography for measurement of FRC, and this machine has been advanced and developed to what it is at present state. So when do we want to measure the lung volumes? The main indication for lung volume assessment is to diagnose and subtype restrictive lung diseases. It helps in differentiating the different types of obstructive lung diseases, that is, differentiate between hyperinflation and air trapping. It also helps to diagnose combined restrictive and obstructive disorders, and also diagnose complex restrictive disorders where more than one mechanism is involved in restriction. So various methods are available to assess the lung volumes. Broadly, we can divide them into three types. One is the inert gas dilution techniques, second is the body plethysmography, and the third is the radiographic methods. So the gas dilution techniques most commonly used are the multiple breath helium dilution technique and the multiple breath nitrogen washout method, both of which measure the functional residual capacity. The single breath helium dilution technique is generally used along with DLCO to assess the alveolar volume, to which when you add the dead space gives you the TLC. Body plethysmography is the gold standard in measurement of lung volumes, and it estimates the thoracic gas volume at FRC, which is then called as FRC pleth. The various radiographic methods include chest radiograph, where both AP and a PA and a lateral film are used to assess the lung volumes. However, this is a very subjective criteria. CT is an upcoming technology for measurement of lung volumes. Initially, just plain CT was used, then volumetric CT, and now you have spirometry gated CT assessment of lung volumes. MRI is a research tool for assessment of lung volumes. So coming to the radiological methods, as I said previously, initially the X-rays were used, both the PA film and a lateral film. Then the CT was developed, and now we have the latest mechanisms coming in. This was a paper in which they had automated estimation of total lung volumes using chest radiographs and deep learning. So basically in this study, they calculated the reference TLC in some people from HRCT chest and in the others from PFT. And then a data set was used to train deep learning architectures to predict the total lung volume from the chest radiographs. They proposed a model that actually predicted the TLC from chest X-ray, and it correlated very well to both the CT and the PFT. Then we had the automated lung volumetry scans from routine thoracic CTs. So basically routine thoracic CTs were performed at full inspiration and expiration, and then from them the total lung volume was estimated. Though it was found to correlate very well with the plethysmography, it was found that the intra-patient variation, that means when the patient does the CT assessment of the lung volumes at two different times, the variation was about 16%, which is a significant amount when you have to follow up any patient with ILD for lung volume assessment. Then the latest study is the evaluation of spirometry gated CT scans to measure the lung volumes, especially in emphysema patients. In these patients, the CT is performed at maximal inspiration and maximal expiration as assessed by a spirometer. So in this study, they found that CT-derived lung volume strongly correlated to the body plethysmography, more accurate with spirometry gating than routine breath holding. Now coming to the gas dilution methods, the first one we will talk about is the nitrogen washout technique. It's an open circuit, multiple breath nitrogen washout technique. It is based on washing out the nitrogen from the lungs while the patient breathes 100% oxygen for several minutes. A normal person is able to wash out the nitrogen in about 3 to 4 minutes, whereas an obstructed patient can take up to more than 10 minutes to wash out the nitrogen. However, as a standard, it is performed for 7 minutes. This method can give highly variable results and may underestimate the lung volumes in obstructive diseases due to differential ventilation. Inaccuracy in measurements of the expired volume or the final nitrogen concentration will also cause a significant error. This is a diagrammatic representation of the nitrogen washout technique, where the patient breathes 100% oxygen from a source and the expired air is collected in a bag with continuous nitrogen analysis. In the graph, we can see there is a gradual and steady fall of the nitrogen fraction in the expired air. We have the nitrogen fraction on the y-axis and the total volume on the x-axis. The area under the curve will give us the total amount of nitrogen that has been washed out. In other terms, the total amount of nitrogen contained in the lungs at the FRC, as seen on the left of the equation, is equal to the total amount of nitrogen contained inside the lungs after the procedure, plus the total amount of nitrogen that has been washed out, minus the nitrogen that has been released from the tissues. In this figure, apart from the FRC, we know all the other values from the nitrogen washout method. Hence, the FRCN2 is calculated using this formula. This generally is done by a computer, so nothing to worry about that. The procedure, the patient is made to sit comfortably. You always inquire regarding a perforated eardrum before the procedure. The patient is explained how to form a tight seal around the mouthpiece, and a nose clip is used to avoid any leaks. Then the patient is asked to perform tidal breathing to ensure a stable end expiratory level. And when the end tidal volume is at FRC, the patient is switched into the circuit. That is, he now starts breathing 100% oxygen. The nitrogen concentration and the volume of the air expired is monitored continuously during the washout, and generally for a total of 7 minutes. The washout is considered to be complete when the nitrogen concentration is less than 1.5% for at least 3 successive breaths. At least one technically satisfactory measurement has to be obtained, and a wait period of 15 minutes in between trials is essential for normal patients, and in patients with severe COPD or bullous disease, the wait time is more than 1 hour. The value reported for the FRCN2 should be the mean of technically acceptable results that agree within 10% of each other. A sudden change of N2% in the inspired air by more than 1%, or a sudden increase in the expiratory nitrogen concentration, indicates an improperly performed technique with a leak. The second gas dilution method is the helium dilution technique. This is a closed circuit multiple breath method. The method is based on equilibration of gas in the lung with a known volume of a gas containing helium. A known volume of air containing approximately 10% helium is used. As we can see in this diagram, C1 is the concentration of helium in the spirometer, V1 is the volume of the spirometer, and once the patient is taken in circuit, he starts breathing this known concentration of helium. Post equilibration, now we have C2, that is the concentration of helium in the entire circuit and lungs. So the only volume not known to us is the V2, which can then be calculated from this equation. The procedure, again, the same as nitrogen washout, ensure that there is no perforated eardrum. The patient is sitting comfortably with no leak, and then the patient performs tidal breathing to assure a stable end expiratory level. The patient is then turned in at the end of a normal tidal expiration, that is at FRC level. The patient is then instructed to breathe regular tidal breaths. The test is continued till the helium reading changes by less than 0.02% in 30 seconds or until 10 minutes have elapsed. The O2 flow is adjusted to compensate for the O2 consumption to keep the FiO2 at or above 0.21. The helium equilibration curve should show a smooth and regular fall of helium concentration. A wait period between repeating the test is 5 minutes, and the measurement of FRC should agree within 10%, and mean of the acceptable measurements is reported. So here you can see the graph. Initially, the helium concentration is FHE1. Then the patient is switched in at FRC, and he does tidal breathing. We can see a gradual and a continuous fall of helium concentration till a plateau is achieved. After the patient is switched out of the system, he performs a spirometry maneuver to get the ERV and the IRV, from which we can calculate the residual volume and TLC. Now coming to the present topic, that is body plethysmography. In 1956, Dubois et al. Described a technique of measuring the volume of gas in the thorax by using the measurement of a volume change when a gas is compressed. It is the gold standard for measuring lung volumes and provides additional information such as resistance and conductance. There are 3 types of plethysmographs available. The most commonly used one is the variable pressure or fixed volume plethysmograph. The second is the volume displacement plethysmograph, and the third is the flow plethysmograph. So body plethysmography works on the Boyle's principle. The Boyle's law states that for a constant mass of gas under isothermal conditions, the product of the pressure and volume of a gas is always constant. So at the fixed temperature, in case the volume of the gas increases, the pressure reduces, and vice versa, such that the product between the pressure and the volume of the gas remains the same. This is how a typical fixed volume plethysmograph looks like. The apparatus is a glass chamber, looks like a telephone booth. The volume is about 700 liters to 900 liters. It has 2 pressure transducers, one at the mouth and one at the chamber. It has a flow sensor and it has a shutter mechanism. So this is the principle on which the plethysmograph works. Basically, when the shutter is placed and the patient is asked to pant, the lung volume increases at the time of inspiration. This is called the shift volume or the change in volume, denoted by delta VL there. An increase in the volume will lead to a drop in the pressure inside the lungs, that is the alveolar pressure, which, as there is no flow during the procedure, is transmitted to the mouth. So the mouth pressure is considered to indicate the alveolar pressure at that time. A change in the mouth pressure on the y-axis and the change in the shift volume on the x-axis gives us this graph, and the slope of this graph helps us in measuring the lung volume. So this is the calculation that is used. P1 V1 equals to P1 minus change in pressure into V1 plus change in volume. So this is derived by the computer. Basically, the volume that we don't know or we're trying to measure is the FRC pleth, which is the V1. The P1 is the mouth pressure at the beginning of the procedure, and delta P is the change in pressure. From this equation, when you simplify it, you come down to this, which is used for measuring of FRC pleth. The procedure, the patient is seated comfortably and the procedure is explained to the patient, including that the door will be closed. Time is allowed for thermal transients to stabilize. The patient breathes quietly until a stable end expiratory level is achieved, usually about 3 to 10 tidal breaths. When the patient is at FRC, the shutter is closed at the end of expiration for 2 to 3 seconds. The patient is then instructed to perform a series of gentle pants at a frequency of 0.5 to 1 Hertz, that is generally at the rate of 30 to 40 breaths per minute. After the shutter is opened, a ERV maneuver followed by a slow IVC maneuvers are performed to derive the residual volume and the total lung capacity. So this graph shows the change in mouth pressure against the change in volume. Repeated attempts should give us similar lines which superimpose on each other, separated by a minor thermal drift. This is a video of how body plethysmography is done. This is the initial, the demographics of the patient are entered. The patient is then seated inside the box and the box is sealed. The patient is asked to sit comfortably without bending his neck and his feet firmly on the ground. He forms a tight seal around the mouthpiece and performs tidal breathing. During the tidal breathing, on the left top corner, you can see graphs which are plotting change in pressure against change in delta volume, change in flow against change in volume, which gives us the resistance. After that, the shutter is given and the patient performs 2 to 3 pants at that time and again returns to tidal breathing. This maneuver is repeated for up to 3 to 5 times till you have 3 acceptable panting maneuvers. Now again the shutter is being closed and the patient is panting. And after this maneuver, the patient exhales to his residual volume that measures the ERV and then inhales maximally, that gives us the IVC. So the procedure can be divided into 3 parts. The initial phase where the patient does tidal breathing. During this phase, the system calculates the resistance loops. Then the shutter is activated and 1 to 2 breaths are given against the closed shutter. During this phase, the system calculates the thoracic gas volume or the FRC pleth. And then there is complete expiration and inspiration to get the ERV and the IVC, with which we derive the TLC and the residual volume. So FRC is equals to TGV, is TGV at occlusion. ERV we get at maximal expiration. IVC we get at maximal inspiration. RV is defined as FRC minus ERV and TLC is defined as IVC plus RV. For the procedure to be acceptable, the following criteria has to be met. The panting maneuver should show a closed loop without drift or other artifacts. The pressure changes are within the calibration range and the tracing does not grow off screen. The panting frequency should be between 0.5 to 1 Hertz. A series of 3 to 5 technically satisfactory panting maneuvers should be recorded. At least 3 FRC pleth values that agree within 5% of each other should be obtained. The reported FRC pleth is the average of the 3 acceptable maneuvers. Apart from FRC pleth, the body box also gives us the resistance. So basically resistance is the shift volume required to generate a certain flow. As you can see in graph 1, which is an upright line with the expiratory limb and the inspiratory limb closely placed together, this is a normal curve. When the curve shifts towards the right side, it indicates increase in resistance. And when the curve opens up, it indicates that the resistance varies between the inspiratory and the expiratory phase. So the second diagram is of increased Raj airway resistance. Third is of probably COPD, like a chronic airflow obstruction. Fourth is of obesity and diaphragm dysfunction. And the fifth is suggestive of upper airway obstruction. Contraindications for body plethysmography, generally it's a pretty simple procedure, can be performed by most patients. However, some people, when the patient cannot enter a closed box, such as when he's claustrophobic, confused state, has a cast, wheelchair bound, morbid obesity, or is on continuous IV infusions or continuous oxygen therapy. The second time where we cannot do body plethysmography is where the conditions in which pressure changes are interfered with, such as when the patient has an intercostal drain, a transtracheal catheter, or a ruptured eardrum. A comparative analysis of the gas dilution techniques and the body plethysmography. So body plethysmography is a fast technique, whereas gas dilution is a time-consuming process. Body plethysmography has a drawback of being performed in a closed space. It is readily repeatable, which is difficult with gas dilution techniques because it takes too long and more time is required for lungs to equilibrate and to clear the inert gas. Body box is more accurate, whereas the gas dilution techniques are less accurate. The body box slightly overestimates the FRC in obstructive disorders, while it is underestimated by the gas dilution techniques. It is difficult to test patients on wheelchairs or stretchers or with IV pumps in body plethysmography, whereas it can be done with gas dilution technique. This body plethysmography is more expensive, is larger in slice, and slightly more complex to interpret, whereas the gas dilution techniques are cheaper and smaller and comparatively easier to interpret. This study was performed to compare the three available ways to measure the lung volumes, that is gas dilution method using multiple breath closed circuit helium dilution technique, body plethysmography, and CT chest. They had 10 normal patients, 20 obstructive patients, and 7 patients with restriction, and they checked in which they gave 3 methods, and all 3 gave comparable results in normal subjects and in patients with restrictive defect. However, the significant lower lung volumes were obtained with the helium dilution technique in patients with obstructive defect. So in this graph, you can see the helium dilution technique gives us lower RV, hence lower TLC and lower FRC. To summarize, assessment of lung volumes requires the indirect measurement of static lung volumes, always needs to be linked to a spirometry, always lung volumes are necessary to diagnose restrictive lung disease and subtype obstructive lung disease. The gas dilution techniques are simple and cheap, but are time consuming, difficult to repeat, and underestimate the lung volumes in obstructive lung diseases. Body plethysmography is the gold standard, easy, reproducible, but may overestimate the volumes in obstructive lung defect. Body plethysmography provides additional information such as resistance and conductance. Thank you.
That was an excellent and lucid presentation by Dr. Pradeep. Congratulations. So the take-home message is very, very clear. To precisely measure the lung volumes, especially for restrictive lung diseases, body plethysmography is the gold standard. So any questions we can take one or two for Dr. Pradeep.
So one doubt actually from my side, this is for all the experts here. See, till now the conventional ways whenever we talk about TLC is the body box or the gas dilution. But now with this advent of this good volumetric CTs, there are several softwares which actually give the TLC. So can we replace that TLC to diagnose restriction or follow patients instead of doing body box? So this is something which has been there in my mind, but I would like to listen from both Pradeep, Talwar sir and other people also.
So I think you need to validate it. Even if you look at old teaching, we had 3 methods, and one of them was using as radiology. And in the past, it was said you take that time radiology was there. So chest X-ray, deep inspiration, lateral view, and there were multiple formulas by which you could calculate the lung volume with the X-ray, looking at it in a sort of a cylindrical manner. CT has changed that, and now you can do it in a better manner. So it would probably be something that is easier to do and may actually change how lung volumes are measured. But it needs to be validated in a proper setting. But I do agree that there are a lot of software which have come up. Our radiologists keep using them, especially when you're having hyperinflation or an emphysematous chest.
Maybe some radiation risk, other things.
Yeah,
There-
repeatability won't be there. Repeatability won't be
Will
there.
be
So
there.
actually, if you need to see the therapeutics monitoring, then ultimately you have to go back to the
Body
the
pressure.
standard. So I think the gold standard will remain the body box.
Yes.
Thank you, sir.
So now we have listened the theory part. Now how we are going to interpret in our clinical scenarios. For that, I request my co-moderator to introduce the next speaker and invite him to give his talk.
Good morning, everyone. It's my pleasure to invite Dr. Deepak Talwar, who's the Director and Chair Pulmonary Sleep Critical Care Medicine at Metro Institutes of Health Sciences, Noida. Sir is no stranger, and everybody knows about Sir, his passion to teach and his passion to keep the academics going. Sir has been teaching in charge DNB respiratory medicine since international journals. Apart from this, Sir has taken an Herculean task, and Sir is the secretary of the Indian Chess Society and has taken up the task of taking the ICS to a new levels. Thank you so much, sir, for coming here, and please enlighten us with the clinical interpretation. Thank you.
Before sir starts, actually we want to make this a more interactive session. So I think sir will be presenting a series of cases, and I'll pass the mic also so that people can actually comment and opine. I think if you make mistakes also, it is not a problem. This is basically a learning experience. So I think you should open up and then comment.
Good morning, everyone, and thank you, Nagarjun, for having me here today to talk about pulmonary function tests. And I think last Sunday, Randeep said that there is a less interest in respiratory physiology, more interest in respiratory anatomy, because of the interventions which are coming up, and have taught everybody that where are those lymph nodes and where are those, their relationships. Anatomy has reached a level where everybody has an interest. But considering that there is so much of newer advances which have come into lung functions, which is a glimpse into the respiratory physiology, why are we not that interested into respiratory physiology? So the huge amount of number of people who are here does testify that how much they are interested in the respiratory physiology equally well. And this session is basically the interactive session. So I would be expecting responses. You need not raise your hand, or you need not stand to talk, but you can just say loudly whatever is the answer, because if you don't, then I'm not going to move on to the next slide, because this is, you have to interpret. You have learned your spirometry, you have learned your lung volumes, you have learned your diffusion capacity. My job is to just put all the things together, connect the dots, and give you a kind of a capsule which you can use in practice as to how this information would help you to translate into a better therapeutics in a patient as far as it's today is concerned, or it's a monitoring like that. So we have already learned that we have 4 capacities and we have 4 lung volumes. I am not going to go into it. We have been learning it right from the first year of our MBBS. And if you do not even remember this, then I'm pretty sure that the next 45 minutes is not going to be useful, because you need to understand this. There are certain volumes and certain capacities which cannot be checked in the spirometry and will require the lung volume. Practically anything which is going into the areas of residual volume, the one which is below that red line, cannot be looked into from the perspective of spirometry. And you need the tests to do it. And one of them has been shown today, that how the body box-plethysmography helps, and that has become a gold standard as of date today. So residual volume, then the capacities FRC and TLC. So these 3 are the most important volume and the capacities of the lung, which are possible only by using the lung volume estimation methods, and the one of them body box, which has been shown. And most of us are using body box now, because this is I think whatever was the comparison given, but by all said and done, this is easiest to replicate. And of course, the variability between the various tests being done on the patient, inter-observer variabilities, are minimal in this. So why do we need to do the lung volumes? Just to recapitulate, that we need to confirm the restrictive lung disease. So remember, all the postgraduates, if you are given a data of spirometry and asked that is it a restrictive lung disease, you cannot comment upon FVC alone. You need a total lung capacity to diagnose restriction. So without that lung volume, you cannot confirm restriction. Yes, you can rule out restriction by telling me that FVC is 85%, but not rule in restrictive lung disease. Subtype the restrictive lung diseases. So restriction may not be due to one disease. Particularly think about a patient of IPF who might be having a restriction related to definitely the pulmonary fibrosis. It can be because of the emphysema. It can also be because of the respiratory muscle dysfunction. It can also be because of obesity, and multiple factors of restriction can be in a single patient, which only shows the TLC is reduced. And then it's your job to look at the various lung volumes and other tests, integrate them to come to a conclusion. That's not one factor, and there are many other factors which perhaps can be corrected better to get a better response in a patient. So in obstructive lung diseases, most of the times we are happy with the spirometry, but we do need to quantify air trapping or hyperinflation, so that we need to know what we actually are going to monitor in future for those patients. And of course, there are cases where you'll have a combined obstructive and restrictive disorders. And lastly, of course, there are complex restrictive disorders also. On a prima facie, it might look that it shouldn't be so difficult, you can do it in easy practice. So let's see how easy it is. But just to tell you, anything between 80 to 120% is normal, whether we are talking about RV, TLC or RV TLC ratio. So the simple numbers, remember them, 80 to 120. And remember that whenever the RV TLC ratio is increased, we do talk about that it is because of obstruction, but it can be because of restriction from the chest wall disorders, where you can get a low TLC and a normal RV and an increase in RV-TLC ratio. So I might be tricking you in some of the cases there. So when you use lung volumes, you have only two types of diseases in mind. Either patient has obstruction or patient has restriction. Everything is reduced in restriction and everything is increased in obstruction. That's a simple way of putting the words, but all volumes and all capacities do not increase or decrease in a proportionate manner depending upon the underlying disease. And that's the most important and the complex mechanisms which we need to understand when we are interpreting the lung volumes to diagnose the obstructive or a restrictive disease, and also going into perhaps their etiologies which might help us to treat them better. So that brings me to the first case. So you can look at this case, and it is given 55 years male, BMI 32, smoker, presenting with shortness of breath on exertion, and you look at this kind of a spirometry. So I'm sure that these kind of pictures have been shown already to you people, and you know that how to interpret it. So is it obstructive or restrictive? What is it? Anybody please answer it. I'm not going to move this slide unless and until I hear something.
Obstructive.
Even if it's wrong, just answer it. Obstructive, restrictive, what is this?
Obstructive.
Obstructive. Everybody tells me it is obstructive. Do you need anything else to say that? As I told you, this is just 55% FVC. So are you so sure that it's just obstructive? Yes, the ratios are there, the FEV1 FVC ratio, you know the algorithm, very correct. But very important thing is whether to know that this restriction of FVC is a true restriction or is it a pseudo restriction. So how do you do it? Anybody? It is being shown in the picture downstairs, in the lower part of the slide, you can see that there is something which is called IC over ERC ratio. So you need the other values to look into it. And these are the values which are given to it. So what has happened? You can see that ERV is relatively preserved, and it is the inspiratory capacity which is decreased. And you can see that when you have IC over ERV ratio, which is less than 2, then it is a pseudo restriction. When it is more than 6, it is pseudo restriction. Otherwise, it's a parenchymal restriction. So in this situation, you would expect that it's not only obstruction, but some amount of some amount of restriction is there. So this is not normal. Perhaps you can look into it, that is it requiring lung volume or not? That's the second question which comes. You have seen the loops, and I'm pretty sure that because of the loops you made the diagnosis of obstruction. You don't even need to read the values of the entire test. But what about the, now the next step when we are talking about the lung volumes. So what are these lung volumes telling you? Can anybody tell me? What are the lung volumes telling us? Is there any restriction or there's no restriction? Is there a restriction there or not? No. Very right. Just say it loudly. You are correct. TLC is 120%. There is no restriction at all. It is a pure obstructive defect. And you can see that TLC is 120. And up to 120, I told you, 80 to 120 normal. It has not crossed the 120 limit yet. RV TLC ratio is 228%. And you can see the residual volume is 261%. So you can see that all volumes are increased, all capacities are increased, although the FVC was low, but this patient has got a pure obstructive defect. Anything else you can interfere from them? You need anything more than that? Or no? Yeah, you need to find out whether these lungs are big because of air trapping or is it because of hyperinflation. What's the difference between air trapping and hyperinflation? Air trapping does not allow the lungs to empty, but they are normal lungs. Hyperinflated lungs are where the alveoli are distended. They are big, and that happens in emphysema. Air trapping happens in diseases like asthma. So there is reversible where you can actually look at it, how good it is. And of course, in COPD, when you have hyperinflation, then you need to look into it that whether this can be approached by another methods for the treatment or not, and whether that can be reduced to some extent or not, unless and until everything is due to the destruction of emphysema. So RV is increased and RV TLC ratio is increased. So they are seen actually both in hyperinflation as well as in air trapping. Is that clear or not? Is that clear or not? So what is difference between the two? The TLC. TLC is increased in emphysema. But is it possible that you can have 120% of TLC and still you can have emphysema? Yes, it depends upon the grades of emphysema. It is still possible. Then what do you do next? You have reached the lung volumes, you have seen the spirometry, and you have not yet reached the question that this entire process, what we have seen in this patient, is because of emphysema or not. So what do you do next? Yeah, you ask for a diffusion capacity for that patient. And this is the single breath diffusion capacity, which is 55%. So is it emphysema now? Confirmed? Very nice. And what do you expect in emphysema next? KCO. What happens to KCO? I'm sure this has been dealt with yesterday again. KCO. So what is it? What is the value here coming? 94%. What are you expecting in emphysema? KCO is also supposed to be decreased unless and until the units are not ventilating at all. The gas has not reached there at all. So that will be happening only in cases there is a huge bulla or something which is not communicating, and hence it is not able to participate in the diffusion process. So it's like not there at all. It will be working like an autopneumonectomy kind of a situation where whatever volume is there, the gas has gone there and given you a normal KCO. KCO is correcting for the alveolar volume. So is it okay? Look at the alveolar volume. It's about 60%. So now, where are we? Is it emphysema, or is it now telling us that it is still not emphysema and it is just air trapping? What is your answer? So obviously now we are looking at when the KCO is low. And it should be low, but it is not low. What could be the causes where it could be? And you can see that low DLCO with normal or high KCO indicates that the remaining lung, whichever it is working well. So pneumonectomy is just one example. It may not be there because pneumonectomy you will know in an individual patient. But others will be non-communicating units. So sometimes it happens that because of the non-communication, you might get it. So the falsely raised KCO can be there. So you need to keep that in mind, that it could be because the VA is reduced. So if the VA of this patient would have been somewhere around 75%, then I would have easily said that KCO is normal. You definitely are not looking at it, the value. You need to look and go back into it, that it's not like an emphysema at all. So have you understood what I said? It seems it's very difficult actually. Everybody is looking very, very exhausted and blank. Is it that difficult to distinguish between air trapping and emphysema in an obstructive disorder? You need to decide on the basis of TLC. But if the TLC is within the normal range, still emphysema cannot be ruled out, and you need to look at the diffusion capacity. Diffusion capacity will be reduced, but then you also need to understand that how much was the alveolar volume. And for that, the correction factor is the KCO. Keep that KCO also in mind. So you don't need just DLCO, RV and TLC, and FEV1 and FVC and their ratio to interpret your spirometry. So in most of the cases, you will require additional parameters to get deeper insights into individual patient. And then future, you need to see that what you need to target for those kind of patients. So this is the algorithm for which you can see that how to go about it. This is the ERS algorithm which is given. And you start with the ratio. Ratio was low in this patient. You have come to the right side. Yeah. So this patient had a ratio of somewhere around 33%. So you have come to this part. Look at the FVC. FVC was also low. We have reached here. TLC was high, so it reaches here. You have come to an obstructive disease. Then look at the TLCO, which is the diffusion capacity, which was again low. You have reached here. Then you reach the KCO. KCO was normal, and you are reaching that something where there is a parenchymal disease associated with it, like bronchiectasis. You go back and look at the X-ray of this patient. Might be having emphysema, but might be also having something additional to it, which is a parenchymal destruction. And that we had right from the beginning in mind. You do a CT scan and you will find that there is a bronchiectasis with the COPD in this patient, not the bulla and other things. So this is the kind of algorithm which you need to put into place in each and every patient. Let's move on to second case. 44-year female BMI 33, non-smoker, presenting with shortness of breath for 6 months on and off, history of some allergies, and you are given already here the spirometry as well as the lung volumes. So what does the lung volumes and spirometry tell you? It's a obstructive defect. Is that right or not? Yes, it is obstructive defect. FEC is 85%. It was 72 to 85, so there is a reversibility in FVC. And total lung capacity is 107%. So it's a purely obstructive defect. But what it is showing is raised RV and RV-TLC ratio. And the ratios at which you call them the amount of the severity of this volumes being affected according to the values which are given, where above 170% is considered as severe. So what will be your inference from this? It's an obstructive defect. Is it reversible? It is. It is only 100 ml. It's only 100 ml, I suppose. How much it is? No, 140 ml. 140 ml, 17%. According to the new ARS guidelines, is it in the reversibility phase? I'm sure it must have been discussed yesterday. Is it in reversibility? Lots of people are saying yes. Is it so? What's the values given in the, pardon? 10% and of the predicted and 200 ml. So does it fit into that? It still comes into a partial reversibility. Yes, volumes are showing a good response, not the FEV1. And that can be seen even in COPD actually. The volume response can be seen even in COPD. But anyways, yes, you can say partial reversibility or reversibility. But yes, there is some reversibility definitely there. And there is a very significant amount of air which is left behind in the lungs in the form of increase in RV and RV-TLC ratio. So is it air trapping or is it emphysema? Or you need diffusion capacity? Answer it fast. Air trapping. Everybody says air trapping, and air trapping is severe. You want diffusion study here? Okay. Now the loop, body box loop. What does it show you? What is it showing here? Actually, it's showing obstruction. That's all? That's all? Now you look at it how it is traced up. This is the inspiratory part and this is the expiratory part. Which is more involved? First thing is the obstruction in both inspiration as well as expiration. But predominant obstruction in expiration. You get it in asthma or COPD? You are confirming asthma here. Correct. Anything else you want here? Anything else? How do you explain the ERV in this patient, which was less? Do you explain the ERV less? Isolated, all the volumes are increased. Only one volume is there which is decreased, which is ERV. How do you explain that? Pardon? Obesity. Everybody has learnt it. Thank you very much. Excellent. Whosoever has taken it is excellent, actually, the volumes. The ERV, isolated ERV reduction, when all other volumes are either normal or raised, is an indicator of obesity. And that you need to keep in mind. The only other factor will be perhaps a neuromuscular weakness, which Randeep is going to talk about in the next couple of minutes. So what about the diffusion capacity? How does it help you in this case? 74%, KCO 102%, VA is 75%. Anything you want to say on this comment? Right? Anything on this? So this is all perfectly in line for an obstructive defect. Are you any wiser by getting all these tests done rather than just one simple spirometry which was there? Answer yes or no. Are you wiser or not? Yes. So say it loudly. This is a lung function summit which is telling you each and every test. And if you tell me that spirometry gave you all these insights of this patient, then I'm sorry. Then I think we are not understood the entire gamut of doing the lung function tests. And that's why, in fact, in our center, we bundle them all together. We never do a spirometry alone. Everything together, and it's all given in a package form. We never ask that first you go do spirometry, come back, show me the result, then we'll do the lung volumes, then we'll go ask for a diffusion capacity. No way. Every test has to be bundled together to give you a deep insights about the patient. And obviously in such point of patients, we know that this is asthma now. This is not emphysema. And we know that whatever reversibility, whatever it is, what we need to target for this patient in future would be to look at that the air trapping which is there. So what we need to monitor at 3 months or 6 months when the patient is doing good or not doing good is to look at again the RV-TLC ratio and RV-TLC ratio, which is the evidence of air trapping. And if we are not able to take care of that, the breathlessness is not going to improve in the patient. So for the monitoring, if we ask only spirometry in this patient, it might show some changes in the FVC as well as the ratio. But then the essence of dyspnea in this patient is translated from the air trapping, which needs to be demonstrated and monitored on the next test whenever it is planned to monitor the progression of the disease. Third case, 59-year male, BMI 34, ex-smoker, having shortness of breath for 1 year, which is gradually progressive and dry cough, and look at the spirometry. So FVC 76% post-bronchodilator, FEV1 72%, and the ratio is coming to 78%. Is this spirometry obstructive, restrictive, or normal? Say it. Obstructive, restrictive, or normal? What would you do? Pardon? What? Possible. So is there any word like possible? Is there any word like possible? I'm sure that if this report goes to the patient and you tell him that it is possible, he'll say, what doc? You got a test done and you're telling me it is possible? What is it? Why? Because they are in the gray zones? That's why you are using the term possible? I am with you people only. I agree. If I get only this kind of a spirometry, I am heartbroken because I am not able to understand what's going on in this patient. He might be having COPD, he might be having ILD. I have no idea what's going on in this patient. And he's hugely obese. It could be just because of obesity. Look at his BMI, 34. So it puts us nowhere. Simple spirometry puts us nowhere actually. So you need to get what? Lung volumes. Yeah, say at least that loudly now. Okay, I'll give you. These are the lung volumes. What do they tell you? What do they tell you? What do they tell you? Restriction. So possible restriction has converted into confirmed restriction because TLC is 67%. Any other thing which you want to add on to that? Any other idea which has it given to? RV-TLC ratio is increased. Does it give you some kind of another clue to it? Some underlying obstruction may still be there despite the FEV1 FVC ratios. So that holy numbers of FEV1 of FVC ratio would be proven wrong when you do the complete test in these patients actually. If you go by that, there will be lot will be missed. So you need to look into that. Yes, that is one of the possibilities which you need to consider. And then again, body box loops. What are they telling you? The loop is open. You can see that. Look at this loop. He has shown you beautifully just before me that the loops are supposed to be, it's supposed to take back the same line back. So there is hardly any gap between inspiratory and expiratory. This loop is open. Open loop means that there is an obstruction. And if it is more away from the line on the inspiration side, it will tell you inspiratory. If it is more towards the expiratory line, it will tell you expiratory obstruction. So there is an expiratory obstruction which is being picked up by RV-TLC ratio. Now you tell me, was this information available to you with the spirometry alone? I think as spirometry was completely lost here. Okay. So move on. Diffusion capacity. Combine with the diffusion capacity. Don't do without a diffusion capacity. What is it showing? 47%. And you can see KCO, which is 82%, and the VA is 57%. Now tell me that, what is it? What is it? Pardon? Sorry, I didn't get it. CPFE. Yeah, that's a simple way of what you're trying to tell me is that there is an obstructive disease and there is as well as a parenchymal disease, both of them possibly in this patient together. And KCO is pseudo-normalized because of the two diseases together. So diseases when there is a combined obstruction and restriction, spirometry may be completely defying all the rules of giving you a diagnosis. and will definitely require a closer look of the detailed test. But that's what the pulmonologists are supposed to do. That's what we are supposed to do every day in practice with every patient. You start doing every patient, you will realize lots of things are coming up at that way. So what is it called? It is called pseudo-normal KCO in these patients. You have a restrictive defect and you have some obstructive defect. You have a severely impaired diffusion capacity, but KCO is normal. And again, it can be falsely normal when both are reduced, VA versus DLCO. And that is why it is very important to go back and look into it. What was the VA? VA is 57% only. While if you look at the total lung capacity, this was 67%. So this is about 10% difference between the total lung capacity and a VA. So that's exactly this much is possible. But if it was too much, then I would have actually more than 10%, I would have considered that there are alveolar units in the lung, or there are units in the lung which are not ventilating properly. And we need to look into it. Is it because of collapse, or is it because of fibrosis which has completely eliminated them, and maybe even a honeycombing in those kind of patients. So you need to remember that even in ILD patients, you can have a reduced diffusion capacity, but a pseudo-normal KCO. So that's a perfectly compatible diagnosis. But another important aspect to remember is that always compare your VA with TLC. So you may not have a luxury of having a dilution method for the total lung capacity as well as the body box method. So if you have, you can easily see that there is a difference between the two, which is more than what it should be, and then that is more than 10%, and then you know that it is because of the definitely non-communicating spaces which are bulle. Somebody said like CPFE. So CPFE would be a diagnosis in those situations where you have a non-communicating bulle in those patients. So you need to consider that. But for our kind of a test, which we have done here, even there, it is very important to look at VA as well as the TLC. And it is not like 85%, less than 85%. Generally, we take 85%. If it's less than that, that will give an idea that it is not only an ILD with an obstruction, but CPFE. But on the basis of this, I won't say emphysema, but I will definitely say that there would be something which is, again there, which is an obstructive defect in those cases. So move on to case study number 4. So somebody has to give me a bell actually as soon as my time is just 5 minutes left. Please, on this side, give me, when 5 minutes are left, let me know. Okay? Or is it already there, 5 minutes? No? Okay, fine. Right. So number 4 study, 38-year-old male. So nobody asked me what is coming on this side actually. Now what are these? These are actually the lung volumes and capacities which I showed you. And the black one is the one which is expected for the patient. The blue ones are the ones which are individually patients. So one look at this, like you have one look at the spirometry to tell what it looks like. One look at these boxes tells you that is it an obstructive or a restrictive, and how the various volumes have been and capacities has been readjusted in an individual patient on the basis of a body box plethysmograph. So 38-year male, BMI now increasing, 38. Non-smoker, shortness of breath for 4 years, gradually progressive in nature. So what is the spirometry? Everybody is expert in spirometry. What is it? Just look at the spirometry, don't look down. Huh? Restrictive, everybody said, excellent. Then we look at the other values and go to the lung volumes and the capacities. Is there anything abnormal finding in here which you have seen here otherwise? Pardon? ERV, because it's already coming in red. I do not know why this machines always flag, which is something which is not correct for this patient, and you need to look into it. In fact, it's a way to tell that this thing needs to be explained, why it is happening here. Everything is perfectly going down. You can see that FRC is reduced, RV is reduced, TLC is reduced. So RV-TLC ratio is still normal, so which is trying to tell us again something. What is that? The disproportionate in the changes which are happening in RV over TLC. So what does that mean? RV is still better than what it should be, right? So what is the reason for here? Not obesity. You can't say obesity. ERV is normal. So that's why it is flagging here that don't consider obesity. So what are the other causes in which this situation can be there where there's a disproportionate change in RV and TLC? Pardon? Excellently, neuromuscular. You need to consider that in this individual situation. And anyways, we have a diffusion capacity 49, KCO has increased now 121, and VA is now 42 again. So where are we now? Still we do not know what's happening actually, right? But we are suspecting that there has to be some reason here which should explain the pseudo-normal ERV in this patient, which is otherwise showing all volumes reduced, looks like simple restrictive defect. So what it means is that again it's a complex disorder where you need to consider additional cause for restriction, which as you said is a neuromuscular weakness. And it can be also like obesity, obstructive airway disease, and you need to rule it out. So I bring it to you again to the body box loop. Is this loop normal or showing obstruction? Normal. Very good. Normal. Yes, you are correct. It's normal. You see that it's very, very narrow, very, very narrow. There's just a little difference between the resistance loops between the inspiration and expiration. So it's looking normal. So there's no obstruction. Even if the ratios are wrong, the body box curves won't go wrong. So there's no obstruction. You're correct. So obesity is one of them which we have considered, but ERV has ruled out obesity also in this patient. And then we are left with the neuromuscular weakness in this patient. Okay. So we move on to the case number 5. I'm not discussing a lot of neuromuscular things because Randeep is going to talk about it. And I think that's the next test which should be added after this spirometry, lung volumes, and diffusion studies and their interpretation. So this is the same case? No, this is a different case. 44 years, male, BMI 28, reformed smoker, shortness of breath of 1 year, and gradually progressive. So where are we in this? Is it obstructive or restrictive? What is it? Pardon? I can't hear it. Obstruction. Restriction. Because you are anyways, everything is shown here in a single slide actually. I think the animations didn't work here. Sorry. Right? So anyways, now you are all experts, so interpret the whole thing. Now I've given you everything. Now you interpret the whole thing. Tell me. A lot of murmuring is going on. 68% FEV1 FVC ratio post bronchodilator, which is what? Well, anyways, it is low only. I will expect that. But again, you know, when we are interpreting the whole thing together, look at the loop. Loop is again opened. So there has to be an obstruction there. You are seeing that the FVC is 60% and you go immediately to TLC. Confirm your restriction by looking at TLC. 66%, no doubt that there is a restriction. Now, with restriction, whether there is obstruction or this FEV1 over FVC ratio is normal, it will be very difficult to say. But look at the loop. Loop clearly tells you that there is obstruction. So this is a mixed disorder which has obstruction as well as restriction. Now try to interpret your other things which are there. And you can see that the TLC is 66, RV is 80%, and FRC is 72%, ratio is 124%. So we are getting a pattern in which we have restriction with obstruction, and obstruction is very significant here, you can see that. And I think those who looked at the spirometry graph also could say that there is a lot of concavity in the flow volume loop, which was also indicating. And in fact, it would have not, on a just spirometry, the restriction would have not been considered, because this graph is very, very typical to say that it is an obstructive defect. Patient is a reformed smoker. What else you want to do for this patient? But TLC is 66%. Now looking at the diffusion capacity, 75%, generally 75% consider again and sitting at the border zone where, you know, it is like, okay, it can be considered as a lower limit of normal, but it can be even considered as normal. KCO is markedly elevated, 137%. What does that mean? What does that mean? So there has to be a cause for obstruction and restriction, which we need to get from this. So what we could get here actually? So looking at just at the X-ray of this patient, this patient obviously had an obstructive airway disease, but primary reason was elevated right dome of diaphragm. He had eventration of diaphragm, which was causing the restriction in this patient. And that's a pseudo restriction because again, in the lung volume units are ventilating properly, right? So what we need to understand is that, what happened? That was which? 5. Okay, yeah. This is the picture which is trying to tell us that, you know, how the distribution of various lung volumes and capacities will occur in various forms of restriction. Obstruction, you have only asthma and COPD, emphysema, not so difficult. But when it comes to the other varieties where the restriction could be because of the parenchymal disease, it can be because of pneumonectomy, it can be because of neuromuscular disease, it can be because of obesity, all of them will have a differential affection of the lung volumes and capacities, and that is what you need to remember. So let's move on to the sixth case, which is 36 years female, 30 BMI, and has shortness of breath for 1 year. So again, I have given you everything for the sake of time. So tell me, what is it? Is it obstruction or is it restriction? What is it? Tell me. Tell me, what is it? Or is it normal? Please tell me. So what you are looking at is the FVC is 78%. Ratio is how much? Huh? Oh, this has been cut there. Okay, never mind. It looks normal only. We can always say that. What about the other things? The total lung capacity 81. Look at the loops, no obstruction. So what is it? Some FVC reduction was there, but there is nothing which is coming out in this patient. She is a young lady, 36 years. We do a diffusion capacity. That is also normal. Then what is it? How do you label it? What do you call it? This is the terminology, non-specific ventilatory abnormality. This is the kind of PFT which you come across in these patients where you have no diagnosis after even a complete thing, and you do not know what is the label to be given. And the label given till date is basically a non-specific ventilatory abnormalities. FVC is reduced, but TLC is normal. The ratio is also normal. And there is no restrictive defect, there is no obstructive defect, but some values are not up to the mark in an individual patient. And these may be consistent with the diagnosis of mild asthma, quiescent asthma, mild combined disorder, and in some young children and females where the test is performed where the FVC is a little lower than what it should be. So this is what is called as non-specific ventilatory abnormality. So what do you do in these days? Yes, I do not know whether IOS has been done or not. You end up doing IOS. So what does it show? What does it show? Reversible small airway disease. You can see the values, you can see the reversibilities, you can see minus 41 AX. So anything above minus 35, that is the change by 35% in AX in a patient. You can see the R5 188, R20 129. So what it shows is large airway resistance 129. So you need to be somewhere around 150. So it's normal. Then total airway resistance 188, which is increased. So if large airways are not affected, then what is affected, which is increasing the resistance? Small airways. So is it reversible? AX minus 41 and D5, D20, which is small airway index, minus 55. So two parameters indicating that this small airway obstruction is reversible. And this is a variety of asthma where it is a small airway predominant phenotype of asthma in this lady. Not a psychological patient, doesn't require antipsychiatry medications. She is an asthmatic. So we need to go into the last test, which is the IOS in these patients. And that brings me to the last case, which is 40 years male, 27 BMI, occasional smoker. He has scoliosis and he has a dyspnea on exertion for 2 years. Looking at this patient, anybody would say because of his scoliosis, he's breathless. And that's all. You can use NIV. He's already on NIV and he's still breathless. Look at the lung functions. What are they showing you? Say loudly, please. Is it a mixed defect or is it just a restrictive defect? Because it's a scoliosis, so you expect it to be a restrictive defect. So what are you seeing here? Mixed. Everybody says mixed. Any reason for the mixed? Because you have seen everything. Hai? And the most important is the loop. Everything. I think Nagarjuna has immediately picked it up and said, everybody, look at the loop. Loops are so important. I do not know in the body box plethysmography why we are not looking at the loops. Loops are giving you the diagnosis actually. Emphysema. Golf hat appearance, everything is there in that. Look at the loops, not only just the values. Okay, so it is showing a combined disorder. So not a simple restriction because of his scoliosis. So we move ahead. We find ERV, 17%. Again, a very low figure. But anyways, if you look at the TLC, TLC is 36%. So when we compare TLC and ERV, we find there's a lot of difference which is coming up here. So maybe the whatever is the BMI, which even is a 27 for this guy, but because of his height being very short, maybe this is an additional factor for restriction. So restriction is very severe in this patient. But anyways, going ahead, looking at the body box. Now what are you seeing? TLC 36% and RV 72%. Again, RV is indicating obstructive disorder, which we have already picked up. So we have restriction because of his scoliosis. We have obstruction, which is because of his smoking history. We would say that it must be because of his underlying COPD. And now another thing which is happening here is, which we need to account for in the lung volumes, is again a very important thing, is there is a hint out there. Can you see that hint out there? Okay, so I'll tell you, when the difference between the total lung capacity and the TLC and the FVC. Now look at the FVC, how much it is coming to? 21%. How much is TLC coming to? 36%. Whenever there is more than 10% difference between these two values, it indicates additional cause of restriction in the patient. So FVC is reduced, TLC is reduced, but FVC is reduced out of proportion. And that is more than 10%. And if that happens, there is an additional cause for that restriction which you need to uncover in this patient. And that's an important aspect for this. And as you all know that the neuromuscular weakness will be the next thing to look for, this what is called as complex restrictive disorders. And these are indicated by the difference between the FVC percent and the TLC percent in an individual patient. More than 10% would be there. And then you need to account for additional factors: obesity, muscle weakness, heart failure, occult obstruction, poor performance. You have seen all these tests. None of them will be qualifying for a poor performance. No question at all. So only things you are left for: obstruction you have already found in that patient. Heart failure need to be evaluated. Muscle weakness needs to be evaluated. Obesity is already there. So do you stop there or you go ahead? You go ahead, definitely, in these patients. And you can see that PI max is 50, which is much below 70, but the most important is the SNP pressure, which is a diaphragmatic pressure, which is just 38. Randeep is going to talk about this, so I'll leave it there at that point of time. And conclude with this slide again. So you have seen one slide which you should take home, is the one, the ERS algorithm. It takes you to 90% of the times to the correct diagnosis, but not 100%. So for 100%, it is the problem whenever there is a combined obstructive and restrictive disorders. And in those situations, the volumes and the capacities adjust in such a way that they may be countering each other and coming up as a normal. So there you need to be very, very intuitive. And of course, a simple chest X-ray will be the next thing to interpret this kind of a lung functions. Thank you very much.
That was a fantastic deliberation, sir. Almost if we had listened this talk, even if we didn't listen other talks also, I think this is summarizes totally PFT Summit. So any questions we can take to 1 or 2 questions before winding up.
So, see, small airway is not picked up actually. You only pick up the large airway there. You only showed 4 loops. There are only 4 loops which are possible. Perfectly right. All those are 4 classical. Large airway obstruction, then emphysema, upper airway obstruction, and obesity. These are and the normal loop. So you have only 5 loops. Small airway is not picked up in that loop.
So one question, sir.
So that will not be able to replace the iOS. So iOS is not going to be replaced. iOS is going to be a part of it. So bundled together, I will tell Nagarjun that make a package, give in a bundle, do everything including iOS. That's what we do.
Now, what should be the ideal sequence of tests when we have to?
Oh, that's the most important thing. When you have to do so many tests in an individual patient, let me tell you, I have never got a complaint that this patient was tired and could not do all the tests. So that, just forget about it. Yes, the sequence is very important. What you start with. That's the first thing. So iOS is the one which has to be started first. iOS has to be done. iOS done by spirometry. After that, followed by spirometry. Then bronchodilator response and then you are going to go on to, then you will go on to your lung volumes as well as diffusion, come down and give them the bronchodilator, repeat their spirometry, repeat their IOS, and last is the spirometry which is done for them. So that's the kind of a loop which is followed in our lab basically.
Excellent and lucid explanation of all the things. I would like to comment because majority of the students may be going to periphery and practicing over there, and simple, properly done spirometry and flow volume loop gives excellent information. And if we concentrate on the shape of the loop, expiratory loop as well as the inspiratory loop, even when figures don't show obstruction, if we concentrate on the loop properly, it definitely gives idea that there is a lot of obstruction. And even if volumes are not done, so people should not get an idea that once we go into periphery, this is sine qua non. So yesterday, it was very clearly shown that flow volume loops give immense informations.
Hello? Yeah. So there is no replacement for spirometry. So I think you, even if the iOS has come, if you ask me that can you only do iOS, I will say never, never, never. So we have to do a spirometry, which is the first tool to be used. After that, if you need to go, then obviously you should never feel that you know that the spirometry is like a very small tool. It is the most potent tool, and I fully agree with Dr. Matin that this you have to learn your spirometry. Even the loops tell you, that shape of the loop tells you that even if the values are normal, there is an obstruction, and you have seen that today. Especially in complex disorders, when you have a combined disorders, then the loop shape itself tells you which is the predominant part, which is trying to be the important physiological abnormality in an individual patient. I fully agree with you, sir, that, and this is only to have a comprehensive view of what is happening in the lung. And I fully agree with Randeep telling again and again that you should know what is happening in the patient's lung. And this is the only insights which you can get with these kind of advanced tests available now.
LCO values? Because I've seen people doing just spirometry and just a basic thing and then doing a DLCO. So does the bronchodilator given change the effect? Change
Dr.
the
Chabra is there, so I will ask Dr. Chabra to answer this.
For this first session, over to the organizers.
So that was a perfect start to the day by both the eminent speakers and the moderators. Thank you all. Now we'll be moving on to the second session for the day on diaphragmatic function testing, FENO, and 6-minute walk test, for which I invite the moderators. And Dr. Narendra Kumar Narahari, who is an additional professor at Nizam's Institute of Medical Sciences. I request the moderators to take over the session and introduce the speakers. Thank you.
It's an honor to invite Dr. Randeep. So we all know him. We have been hearing him at many conferences. And he is the chairman of Institute of Internal Medicine and Respiratory and Sleep Medicine, director, medical at Medanta Hospital. He's the president of AIMS, Bilaspur, and ex-director, All India Institute of Medical Sciences, New Delhi, member of National Task Force and Empowered Group for Government of India for COVID-19. We all heard him on the TV day and night, and former professor and head of pulmonary medicine and sleep disorders at AIMS, New Delhi. And he was the recipient of the prestigious Padma Shri in 2012 for medicine, and he has been awarded the prestigious Dr. B.C. Roy National Award for Eminent and Model Person for the year 2014.
Thank you.
I invite you, sir, to deliver your lecture.
Thank you. Good morning. I'm now following Dr. Talwar, which is always very, very difficult. And the topic that I'm going to talk to is also a little difficult. So I'll run you through what are the various tests which we can do for assessing the diaphragm, from the basics to the more complex and those which involve more specialized labs. And in the end, I'll just give you 2 slides as to how at a smaller area or at a primary level, you could just evaluate a patient for diaphragmatic weakness. Now, the respiratory muscle function is often neglected as far as day-to-day practice is concerned. But it's important when you're looking at unexplained dyspnea, neuromuscular disease, as we saw in the PFT session, and non-invasive ventilation will usually help. And this can also occur in various other disorders as a comorbidity, especially when you have patients in the ICU because of malnutrition, steroids. All of this may cause respiratory muscle weakness. Diaphragm is the main muscle of weakness, a muscle of respiration, and it's a musculotendinous structure. Interestingly, and that's why it's very fascinating, it is basically separating 2 areas, one which has a positive pressure and one which has a negative pressure. The chest has a negative pressure and the abdomen has a positive pressure, and that's what makes it fascinating when you're trying to assess diaphragmatic function. Injury can play a significant role. You can have diaphragmatic dysfunction in phrenic nerve injury, neuromuscular disorders after abdominal and cardiac surgery. Critically ill patients, you have what is known as ventilatory-associated diaphragmatic dysfunction. Trauma can cause it, and many disorders itself. So there's a whole list of unilateral causes of diaphragmatic weakness: infiltrative processes, trauma, inflammation, neurological disorders, and idiopathic. And you also have a cause which is of bilateral diaphragmatic palsy, which can also occur because of neuromuscular diseases, myopathies, connective tissue disorders. And it's important just to keep this in mind when you're trying to look at causes of diaphragmatic weakness. How do you assess the diaphragm? And there's a whole list, because it's a fascinating muscle that you can assess by looking at spirometry. You could look at pressures, you could look at EMG, you could look at radiology, and all of that will give you information as far as the diaphragm is concerned. So the whole list of tests that can be done as far as diaphragmatic function is concerned. When you look at clinical assessment, generally it happens in patients with neuromuscular disorder. They're breathless, they have tachypnea. Classically, the breathlessness is more when they're lying down on a sitting, and especially if there are some patients who will say, when I enter a swimming pool or go into the sea, I get more breathless. Because as the pressure in the abdomen becomes more and more positive, as they enter the water, the diaphragm gets pushed up and causes breathlessness. It can cause nocturnal hypoventilation, important thing to keep in mind, can be a cause of recurrent aspiration, and can also cause cor pulmonale leading to pulmonary arterial hypertension. Classically, what we teach at the bedside is to look for paradoxical abdominal movement. You have those classical signs of a seesaw movement or indrawing during inspiration. But it's important to remember that these features occur when the diaphragmatic strength is actually decreased to 1/4 of normal. So these are signs which tell you there's significant diaphragmatic weakness, and therefore if you're looking at early stage of diaphragmatic weakness, this may get often overlooked. Lung function, we've already had a detailed discussion, therefore I'm not really going to go into this in great detail, but your lung volumes are decreased, DLCO remains normal when corrected. The important thing is you could look at your lung function in a supine position. So if you do a PFT in a person who's sitting and then you do it when he's lying down, you'll have more than 25% fall in your vital capacity, and that itself is a simple test which will tell you that there is likely to be diaphragmatic weakness. The test, however, requires the patient's cooperation, and those of us who've tried to do this find at times it's difficult to do it in a respiratory lab, but it is sometimes something that can easily be done. It may sometimes be actually non-specific and non-diagnostic. So the simplest test that was initially done more holistically was what was known as mouth pressure. And it is basically a global inspiratory and expiratory muscle strength evaluation. You have the maximum inspiratory pressure, the MIP, and the maximal expiratory pressure, which is the MEP. And this is basically done by just asking the patient to take a deep breath. When you're looking at your expiratory pressure, you take a deep breath, going almost up to total lung capacity, and asking the patient to breathe out maximally into a machine which will measure the pressure. And when you're looking at the inspiratory pressure, you do it at residual volume or at RV and TLC. Usually, again, 3 tests with maximum effort are usually made, and it's sometimes difficult for patients to do it, and if the patient is sedated or uncooperative, it may not be possible. So this test has evolved, and I'll just give you how it evolved. This is what we used to do 30 years ago. We used to use a mercury manometer with a mouthpiece, and we used to look at the mouth pressures using this test. And this is something that I did when I was a resident. And I was at PGI. We published a paper also where we tried to develop nomograms for maximum expiratory and inspiratory pressure. As far as young teenagers were concerned, we actually went to various schools and colleges and did the MIP and MEP in almost 700 children, using out doing a questionnaire to see that they're healthy and try to derive nomograms. This was also done subsequently by Dr. Pandey at AIMS, where MIP and MEP values were derived. It subsequently evolved into simpler ways of doing it. This is a mouth pressure meter where you can actually look at the MEP. This is an older one which we used to use, but now you have better ones which are available, where you can use a mouth pressure meter which gives you an idea of the maximum inspiratory pressure and the maximum expiratory pressure. It's simple. At times patient is not able to perform the test. The glottis may be closed and you may get an abnormal value which is not correct. And at times the buccal pressure may contribute to the overall pressure. Again, most of these tests, remember, have a negative predictive value, and that is very, very important. If they are normal, they rule out respiratory muscle weakness, but if they are abnormal, it may be just a poor effort by the patient rather than actually muscle weakness. Then you can have more specific pressure, what Dr. Talwar mentioned, SNPs, which is the sniff nasal inspiratory pressure. If you want to look at the diaphragmatic contraction, one other way to do is ask the patient to take a short and sharp sniff, and the diaphragm suddenly contracts. We do that in fluoroscopy, but can you do it in terms of looking at the pressure that you measure? And if you do a snip, your esophageal pressure is open, and your pressure at the nose actually is equivalent to the pressure at the lower end of the esophagus. So in normal individuals, the pressure in esophagus and the nose shows close relationships. So P esophageal is equivalent to SNP, and that helps you. And like again I said, it has a value that if it is more than 70 centimeters of water in men and in women more than 60 centimeters of water, it would rule out a significant respiratory muscle weakness. So this is the same device. You have a SNP meter. And again, we evolved over a period of time. In the early days, I used to go to the dental department, make nasal bungs, use them to put into the nose and ask patients to snip. But now you have better devices. They're available. And you just put it into the nose. It's connected to the meter. And you ask the patient to take a short and sharp sniff. And that short and sharp sniff will give you a value which gives you the SNP, which is the sniff nasal inspiratory pressure. So this meter will give you both MIP, MEP, and SNP, that is maximum inspiratory, expiratory pressure, and the sniff nasal esophageal pressure. And this is something that we've been doing for years. This is one paper that we published long time back, where we looked at patients with renal transplant, pre-transplant and post-transplant, and showed that both the MIP and MEP and the SNPs improved significantly if you looked at these patients post-transplant, suggesting that there was respiratory muscle weakness during the time the patient had chronic kidney disease. Coming to imaging, there are a lot of imaging techniques that are available. You do a plain X-ray, which shows you whether the diaphragm is elevated or not. And classically, we use fluoroscopy, again asking the patient to take a short and sharp sniff for looking for paradoxical movement. It's not useful if there's bilateral diaphragmatic palsy, because then you will not be able to see the paradoxical movement. So you will have elevated dome of the diaphragm, and you can use this as one test to diagnose diaphragmatic weakness. But one other test which has usually made a huge difference in our current evaluation, and we're trying to look at it both from the physiology and the anatomy point of view, is the use of ultrasound. Ultrasound has now become a non-invasive technique, safe, easy to use. It's a bedside modality, accurate, and it overcomes many of the standard limitations of imaging. It's important that you have a good image, and I remember maybe 20, 30 years ago, when we started looking at ultrasound, at that time we had a big fight with the radiology department because they felt we were encroaching into their area. Now critical care ultrasound is something standard, but we had a lot of issues of trying to find the image and find the diaphragm, but you learn a lot with time, and it's something that's easy to do. You use two probes, the curvilinear and the linear probe, and you try and measure the diaphragmatic movement and the thickness. So you use these two probes, which are used, and the first thing that you try and do is look at the diaphragmatic thickness. And as you can see, you have the pleural layer, the peritoneal layer, and in between, you can measure and see what is the diaphragmatic thickness. So this gives you an idea of diaphragmatic thickness, and what you're looking at is what is known as the zone of apposition. The zone of apposition is the area of the chest wall where the abdominal contents reach the lower end of the rib cage. So you have the liver and the lung, and this gives you a nice window to be able to see where exactly your diaphragm is. So this is what you do on the right side, that you put your probe there and you try and look at the zone of apposition. You do it on the left side, and you get a nice movement where you can see that this is where the diaphragm is, and the two lines you can see, and you can measure when you freeze the image, you can measure the thickness of the diaphragm, and you get various values. So you can get the diaphragmatic thickness, the TDI, which is measured at end expiration, and it's usually more than 0.15 centimeters. But what you often also look at is what is known as diaphragmatic thickness fraction, TF or TFDI, which is the measurement at both end expiration and end inspiration of the diaphragmatic thickness. And a ratio is calculated, and this is expressed as a percentage. And again, if you look at this ratio, the lower limit of normal is 20%. So again, if it is less than 20%, if your TF is less than 20%, you're again looking at diaphragmatic weakness. And this is a simple test that can be done at the bedside itself, and something which one tends to do more and more often in an ICU setting, because it's something that is easy to do and you don't have to shift the patient. Then you also look at the excursion of the diaphragm, the diaphragmatic movement. And here you look at the right and left costal margin, either in the mid-clavicular line, or you look at the interior axillary line, wherever you get a nice window. Probe is directed medially, cephaloid, and dorsally. And if you first use a 2D mode where you best obtain the line that you want, then you go to M mode, and looking at the measurements, you're able to measure the diaphragmatic excursion. So here, this is what you do. You have the probe put here, and then you look at the diaphragmatic movement which occurs. Okay, this is not visible here. But what you do is you look at the diaphragmatic movement during expiration and inspiration, and you get the chart like that. That is quiet breathing, deep breath, and that is what is known as a sniff, a voluntary sniff that the patient does. So by this, you can actually measure the diaphragmatic movement. Again, the probe is put at the subcostal area. You look at the a nice window that you get, and then you subsequently are able to measure the diaphragmatic excursion, depending whether you want to do it at tidal volume or you want to look at a maximum excursion. So you get a movement like this, and you freeze it, and then you're able to measure the diaphragmatic excursion. And this is something that one does as far as routine practice is concerned. So again, the diaphragmatic excursion, which is known as XDI, has been shown to be reproducible related to transdiaphragmatic pressures. And again, we have lower limits of normal, 3.7 centimeters in women and 4.7 centimeters in men during a maximal inspiratory effort. So you ask the patient to take a maximal inspiratory effort, you look at the movements, you freeze the frame, and then you calculate the distance, and that gives you the diaphragmatic excursion. Now coming on to more invasive tests, these are simple tests that can be done. But what are the other tests? And the other tests are trying to look at the diaphragmatic pressure. And the diaphragmatic pressure are done by putting in balloons. And it's something which looks very complex. I've probably put in more than 100 balloons in myself. So I can tell you that in the early stage, it's very difficult. You put it in your nose, you swallow it, you start drinking water. And as you drink water, the balloon actually goes into your stomach. And then you can see the positive deflection. As for intra-abdominal pressure, you withdraw one balloon, and as soon as you see a negative reflection, you know that now you're in the esophagus, and you can now look at the pressure, which is the transdiaphragmatic pressure. Esophageal pressure and gastric pressure PDI actually are also used for dynamic compliance, and it's something which can be done. This is something which is more reliable. So we have what is known as the transdiaphragmatic pressure, which is relatively invasive. You can use a single balloon. I'll come to that, but you can use two balloons also, an esophageal and a gastric balloon. Difficult to do in routine practice, and that's why I said this is something that I'm trying to tell you, which is more at an advanced stage, but it's good that you have an idea about it, and it's useful in patients with respiratory muscle and as a research tool. So what you do, you have two balloons which you put in through the nose. You have a balloon which you put in, which you place in the lower end of the esophagus, and one which is in the stomach. You can also use a single balloon. We've done that in some of our patients, that we've used just a single balloon to get what is known as esophageal pressure. And by doing this, you get your tracing, which gives you an idea of what is known as a transdiaphragmatic pressure. So I'll give you the terms that we use. The PDI is the transdiaphragmatic pressure, which is the gastric pressure, which is positive, minus the esophageal pressure. The P gas is the positive deflection that you see, which is the abdominal pressure. The P esophageal is the negative deflection that you see, which is the intrathoracic pressure. And when you stimulate the phrenic nerve, then you get the twitch PDI, which is the transdiaphragmatic pressure, which you can do by using a magnet or by using electric stimulation. And if you ask the person to take a short and sharp sniff, and you get the pressure, that becomes the transdiaphragmatic pressure at sniffing at full inspiration. So you can do all of this also, but this is more at a high end rather than what I showed you in the beginning in the form of MIP, MEP, SNP, and the ultrasound. So what is the sniff? Sniff, you can measure what is known as sniff PDI. You put in the balloons and ask the patient to take a sniff, and this will give you an idea of the transdiaphragmatic sniff pressure. This is sometimes helps you in differentiating, and about 1/6 of patients with low MIP have normal sniff PDI. If you want to put in only one balloon, and we've done that, then you can measure what is known as sniff esophageal pressure, which is also a good surrogate marker of sniff PDI. So just hear this out. I know it's going to be more and more complicated, and in the end I'll show you the simplest way to approach these tests. So sniff PDI, sniff esophageal pressure is more accurate, invasive, difficult to do in routine practice, but patient's cooperation is needed. But something that can be done. We've published papers on this. I'll just show you one. This is one paper that we published where we looked at patients with Graves' disease and tried to look at the reversibility of diaphragmatic weakness with carbamazole therapy. So what we did was we took patients with Graves' disease, got them into the respiratory lab, put in an esophageal balloon, and this is the one representation of a patient. At that point in time, we didn't have the monitors, so we did it using a kymograph. Now you can have an A to D board, and you can it comes on your computer screen. But this is a patient taking short and sharp sniffs, and you'll be able to measure the sniff esophageal pressure. This positive reflection, the positive reflection that you see there is the patient swallowing. And then again, after giving therapy, we put in the balloon again. The fact that the patient agreed to have the esophageal balloon put in twice would tell you that it's not as difficult as it made sound. So all of these patients had an esophageal pressure, sniff esophageal done before they took the medication and after they took the medication. And it was something that can be done. Then coming to non-violational tests, here in all of the tests that I've told you right now, patient's cooperation is important. Patient has to sniff, he has to blow out into the machine. Now we come to tests where cooperation is not required, where can you stimulate the phrenic nerve and be able to then see what is the diaphragmatic contraction. Traditionally, one used to use electric stimulation. You used to put a probe at the medial part of the sternocleidomastoid, somewhere around here, and then keep stimulating to find the best position of the phrenic nerve. We don't do that now. We use what is known as magnetic stimulation of the phrenic nerve, and this is the gold standard as far as the diagnosis of diaphragmatic weakness is concerned. Electric stimulation was something we did in the past. We currently use magnetic coils, and a pulse magnetic field is usually generated to cause stimulation of the nervous tissue within the field. We use a circular coil which is put at the back, which is what known as cervical magnetic stimulation, because the phrenic nerve comes out from the lower end of the cervical spine, and you can stimulate both the phrenic nerves in one go. And you have a figure of 8 coil where you put anteriorly, which is known as the anterior magnetic nerve stimulation. It's painless, but when you do it, it stimulates your brachial plexus also. And when you do this, you will find that your shoulder also goes up a little bit because the lower end of the brachial plexus is also stimulated. So the coil is put something like this. You put a mark to find out, to find out where exactly you get the best this thing. You create a magnetic field, and you are able to then find out the transdiaphragmatic pressure. So this is how it's usually done, that putting in a balloon, and then this is looking at the anterior stimulation. You see these 2 coils which are put anteriorly. It can be done in an ICU setting, and like I told you, you get the esophageal pressure, the gastric pressure, and the transdiaphragmatic pressure. This is something that we've been doing in our lab also. This is the type of balloons that we use. This is the coil that is used. We use the Maxter magnet, which is basically for magnetic stimulation of the phrenic nerve, and this gives us some idea. So what we do usually is put in the balloons in the patient where we suspect diaphragmatic weakness. We put in an esophageal and a gastric balloon, and like I said, the balloon first goes into the stomach, you get a positive pressure, and then you withdraw one till you reach the lower end of the esophagus. You look at your tracings, and then you stimulate the nerve, and you look at what is something that you can get as far as stimulation is concerned. There's a lot of studies which have been done. We did a study long time back when I was in UK, where we even looked at magnetic stimulation of the abdominal muscles in human, which is also something that was quite useful. Another way that you can look at the diaphragm, and I'm not going to go into this, is by the EMG. You can put your probes at the identify the diaphragm on ultrasound, put the electrodes there, and by EMG also you can look at diaphragmatic contraction. This is something which is done in more sophisticated research labs. Another area which is interesting is to look at endurance of the diaphragm and diaphragmatic fatigue. Again, an area which I'm not going to discuss, but interestingly, this is a project that I had done long time back, where we found that the diaphragm has more of central fatigue rather than peripheral fatigue, and we see more of central fatigue of the diaphragm rather than what is seen in the quadriceps muscles. Coming to what is the most important slide for you, how do you approach a patient with unilateral diaphragmatic weakness? I think here what you should see is if you have elevated hemidiaphragm on the chest and you do a neck and chest scan, there is phrenic nerve palsy suspected, the first and simplest thing to do is do the lung function testing. If your vital capacity is less than 80% of predicted, and you find that there's a decrease in vital capacity more than 50%, if you ask the person to lie supine, or your MIP is less than 60%, then you are thinking of diaphragmatic weakness. Then the simplest thing to do is an ultrasound, and if you find that the thickness fraction is less than 20%, remember I told you that 20% is the lower limit, or you find paradoxical movement on fluoroscopy, then diaphragmatic weakness is likely. If you have the test available, then you can do a unilateral phrenic nerve stimulation, and if your twitch PDI is less than 10 centimeters of water, that confirms diaphragmatic weakness. And then of course, in such a situation, one would also like to do a sleep study to look at nocturnal hypoventilation. So this would be the flow chart and when you have unilateral diaphragmatic weakness. For bilateral diaphragmatic weakness, again, if you have a person with unexplained dyspnea, exercise intolerance, respiratory failure, again, look at the lung function. If your vital capacity is less than 50% of predicted, and it decreases by more than 30% when you ask the person to lie supine, or your MIP is less than 30%, you should suspect bilateral diaphragmatic weakness. And again, then you do functional imaging. The thing that you can do is an ultrasound, and if your thickness fraction is less than 20%, again, you're looking at possibly diaphragmatic weakness. If you have bilateral phrenic stimulation possible, then your twitch PDI of less than 20%, 20 centimeters of water, will tell you that there is diaphragmatic weakness, and that will give you a diagnosis of bilateral diaphragmatic weakness. But even if you just did the functional imaging and you did your lung function, you could get a reasonably good idea that you're looking at diaphragmatic weakness. So simple tests can be done, but if you want to do more sophisticated tests, then the best is a non-volitional test, which is looking at stimulation of the diaphragm, especially looking at phrenic nerve stimulation, either cervical or anterior unilateral stimulation. So I'll stop here, and if there are any questions, I'll be more than happy to answer. Thank you. It's a little complex topic, so I hope you were able to understand it.
For the clinical diagnosis, the transdiaphragmatic pressures performance is how frequent and how far it is helpful?
So we do it in two circumstances. One, like if you have unexplained dyspnea in a patient and you're thinking that there could be diaphragmatic weakness and the diaphragm seems to be very high, but you're not very sure, then putting in the balloons does help. It also helps sometimes when you're trying to look at patients with neuromuscular disorders and you want to see what is the contribution of the diaphragm as far as that weakness is concerned as compared to the other muscles. But like I said, I would say for the students that just doing the ultrasound and your lung spirometry would give you a reasonably good diagnosis of diaphragmatic weakness. The remaining part of the test, which I just mentioned because I think it's important that you're aware of it, are something that are done more in limited laboratories, but it's something that students should be aware of, that there is, you can look at diaphragmatic stimulation. Phrenic nerve stimulation is something that is done in some labs in our country.
P.1 or P100 is indirectly indicative of respiratory drive. What will be the impact of diaphragmatic weakness on that?
So P.1 is something that we look at when you have a patient and you're in an ICU setting, and that gives you some idea of the feedback in terms of the respiratory drive. It does have some utility. It's something which is not that commonly used, but it is a useful way of trying to look at the respiratory drive, which is more centrally mediated as far as stimulation of the diaphragm is concerned. When you're looking at diaphragmatic weakness, we're looking at what we're seeing as far the muscle is concerned. Remember, if you have, let's say, injury to the phrenic nerve, then your phrenic nerve conduction test will not really show anything, because the stimulation will not cause any contraction, and that's where you will rely more on the ultrasound.
Sir, if I am not clear in my asking, what I am asking is what will be the impact of diaphragmatic weakness on P100, if at all you can comment on it.
So like I said, P100 gives you an idea of central drive as far as the muscle is concerned. So if you have anything which is above that, let's say at a central level, you will have diaphragmatic weakness, but that will be something which will not be picked up in terms of the test that you're doing, except for the fact that diaphragm will move in a flabby manner, but no contraction will be able to be seen if it is much more above that.
But the pressure is generated by the diaphragm, so theoretically the P100 becomes invalid if there is diaphragmatic weakness.
So P100 will not be of much use because of the fact that it's not showing, the loop is not completed.
Sir, how can with this we apply for the patients who are on ventilators, where how can we assess on them? Because of critical illness, neuropathy or myopathy, or for diaphragmatic palsies, how can we test for these patients? We may sometimes feel failure to wean them, so how can we assess?
So two things are done. One is you do an ultrasound. There is a lot of focus on looking at ultrasound and diaphragmatic thickness and movement as a test for weaning. What we've also trying to do, and this is something which is part of a research project, can we combine phrenic nerve stimulation with ultrasound, and you don't have to put in the esophageal balloons? So can that help you in terms of diaphragmatic weakness? You stimulate the phrenic nerve, and you look at the diaphragmatic contraction, and you measure that, and use that as a surrogate marker of the transdiaphragmatic pressure. But that is something that is being done, trying to combine ultrasound with phrenic nerve stimulation. But currently what is useful is looking at the ultrasound. So diaphragmatic thickness and movement is something which is, there are a large number of papers which have used that as an indicator for weaning failure.
Okay. Thank you.
Any questions from the students?
Okay, thank you. Thank you very much, sir.
Thank you.
The next speaker is Dr. Richa Gupta. She is professor and currently heading the Department of Respiratory Medicine, CMC Vellore. She has more than 50 publications, and her special interest is on pleural diseases, medical thoracoscopy, and chest ultrasound. And she will be delivering a talk on FENO, when to do, and how to interpret the test. And over to Dr. Richa Gupta.
Thank you so much, sir. From the already established case, not this one, the other one. From already established lung function test, we are now moving on to another entity which is little different. In a way, it is very, very easy to perform, unlike the other PFTs which we have seen, and but a little underutilized modality. So this is all about FENO. The topic was when to do, and how to interpret, and that's the objective of the talk. But before even we move on to, we just have a little bit about the physiology of what exactly we are talking about. The nitric oxide, what we talk about, is present in all the organs, and it has a wide variety of functions. But the importance of nitric oxide was only established in late 1990s, and the importance of NO in lung was discovered in early 90s. To be precise, it was first described as an endogenous in exhaled nitric oxide, exhaled breath only in 1991. Now, since then, it has become an area of research, especially as a biomarker for Th2 pathway for inflammation. Don't underestimate the nitric oxide. The discovery of NO as a cardiovascular signaling molecule actually made the researchers won the Nobel Prize in 1998. If we look at where and how it is present, so there are three. The nitric oxide is produced by NO synthase, which is also known as NOS, and L-arginine is its substrate, right? There are three isoforms. This is important to understand or to even at least know: constitutive NOS and inducible NOS. Now, our focus will be more on the inducible or the INOS we are talking about. The constitutive forms of INOS are described or named after the area where they are present. So N-NOS is neuronal and E-NOS is endothelial NOS according to the site of expression. So they are mainly present in nerve cells and endothelial cells respectively. Now, activation of this C-NOS, it occurs in response to a calcium signal. And it produces basic levels of NOS, which is rapid but very short-lived. But when we come to the inducible nitric oxide, which is the name, as the name suggests, it is produced in response to the inflammatory cytokines, right? Mainly which are expressed in the epithelial cells or the upper airways or the lower airways we are talking about, in addition to various other inflammatory cells like macrophages and eosinophils also. In contrast to CNOS, which we said that it is produced in response to the calcium, this is independent of the calcium, and it is mostly produced in response to the inflammatory, it is present in very smaller levels in the normal healthy airways to produce the physiologic response, which is important for the functioning of the airways, right? So if we look at this healthy subject, which is on the top, and then we look at the patient with asthma. Healthy airway epithelium they also have INS. If you will look at, I'm not able to point it out. But the NO produced in the healthy subject is at a very, very micro level, femtomolar to picomolar levels, and it is fundamental for respiratory physiology. This basal production is induced by interferon gamma through STAT1 pathway, right? But what happens is, we don't have a pointer, okay. What happens is in patients with asthma, here it is whenever there is an Th2 pathway, whenever there is expression of type 2 inflammatory cytokines like IL-4 and IL-13, they activate the STAT6 pathway, which causes overexpression of INOS, and that leads to the overproduction of nitric oxide. Now, you have to understand that this is the basic of the Th2 inflammation and what all we will be discussing later on. Nitric oxide in very, very minute levels is essential for the normal physiology of airways, but when it is overexpressed, then the role turns off completely. As you can see, depending on its concentration from physiologic condition to the pathophysiological effect, the change can happen. For the normal physiology in very micro levels, it is required, it can be as a bronchodilator for surfactant production, to regulate the pulmonary blood flow, to even to regulate the tone of the airways. But when it is increased, when it is overexpressed, then everything changed, the role changed completely. It leads to bronchial hyperreactivity, mucus hypersecretion, vasodilation, pro-inflammatory effect, and even inhibition of the ciliary motility and production of more free radicals. So excess of anything, we say, excess of anything is bad, and that is what we see over here. So with this baseline physiology and understanding how important NO could be, we come to the concept of FENO, which is measurement of fractional nitric oxide concentration in the exhaled breath, right? All humans, all of us exhale nitric oxide in our breath, and in healthy individuals, about 40 to 45% of the airway NO is produced in the lower respiratory system, and rest is from the upper respiratory system. Measurement of this exhaled NO has been standardized, and that is what is commonly called as FENO. After understanding this basic things, let's go how we can use FENO in our clinical practice. There are few things. I mean, it is a marker of Th2 inflammatory pathway, more precisely eosinophilic pathway. So certainly it has to do something with the asthma, and that is what has been studied very widely in asthma. So can FENO be used as a diagnostic test for asthma? So in addition to the clinical history, reversible airflow inflammation, airway hyperresponsive. So those are few things which we need to make a diagnosis. Don't you think that presence of airway inflammation, which may be, what are the markers of or biomarkers of airway inflammation? The most commonly we talk about it, the sputum eosinophil or the peripheral blood eosinophilia, right? Tests have shown that sputum eosinophils and the eosinophil in the sputum, induced sputum, as well as the one which is present in the peripheral blood, more or less correlate to some extent. So FENO is again another marker, another biomarker of the same. I'm going to give you some studies to make you understand that this has been studied widely, and there is an evidence how it can be used. So analysis of 43 studies shows that high FENO, if it is present, it increases the likelihood of asthma by 3 to 7 times, depending on how much is the FENO level. Again, there is a systemic review and meta-analysis of use of FENO in the diagnosis of asthma in steroid-naive patient, and they found that the diagnostic odd ratio is about 9. The specificity of this test to diagnose asthma is about 82%, which is little superior to the sensitivity, which is at 65%. So what does that mean? Better specificity, but low sensitivity. What does it mean? What does it mean? That FENO is better at ruling in the diagnosis of asthma rather than ruling out. Is it clear? All right. Then what does the guideline says about the use of FENO in the diagnosis of asthma? ATS and ERS both recommends the use of FENO to support a diagnosis of asthma where the objective evidence is needed or when there is uncertainty about the diagnosis after spiro and bronchodilator reversibility test has been done. So we have to be very careful. It is not proposed a test for the diagnosis, but to support the diagnosis of asthma when you need an objective evidence. NICE also recommends, as a part of the diagnostic workup, upfront they put it up whenever the diagnosis of asthma is being considered in adults or where the diagnostic uncertainty is there for asthma, especially in children. How about GINA? What does GINA talks about? What does GINA says about FENO? Anybody has read the new GINA? So GINA guidelines, they acknowledge the role of FENO as a marker of identifying the eosinophilic inflammation, right? But they do not currently see a role of FENO in the diagnostic algorithm for asthma. So they say it is good, it can identify airway inflammation, eosinophilic airway inflammation, but not to be used for the diagnosis. It's not moving. Yeah. Sorry? Yeah, okay. Then after finding out, yes, it can support the diagnosis of asthma, let's see what else we can do it. So understanding the future risk is an important component when we stratify the patient's treatment, isn't it? It's very nice to know whether this patient is at increased risk of exacerbation or not, so that we can accordingly plan the treatments. Increased FENO levels is associated with increased risk of exacerbations, accelerated decline in lung function, as well as associated with the poor lung function in long term. So this is a post-hoc analysis from the Liberty Asthma Quest study, where they found that patients who have a high FENO of more than 50 parts per billion, they have 1.54 times more increased risk of exacerbations. Sorry. Similarly, if we combine this with increased levels of blood eosinophil counts and look at the more exacerbation, if the patient has exacerbations, previous exacerbation last year, the risk increases more. It becomes almost 4 times. Coming to, we are talking about that FENO is good for identifying the airway inflammation, the Th2 inflammation, and preferably the eosinophilic inflammation. So whenever we talk about the eosinophilic airway inflammation, we know inhaled corticosteroid does help, right? I'm sorry about this. So in a randomized crossover trial, which is called as phenotype trial, in mild to moderate asthmatics, ICS therapy resulted in a significant reduction in FENO. Now the benefit of periodically reassessing the airway inflammation using FENO in chronic asthmatics was demonstrated in a landmark study by Smith et al. Now this is a very old study, it was done in 2005. They took 2 groups. One group, they used to guide the treatment based on the FENO, and the other group was the normal guideline-based care, where you use the clinical symptoms and the spirometry. They observe these patients, they guide the treatment over a period of 12 months, and at the 12 months of treatment, they found that the patients who were managed based on the FENO-based approach, the dose of ICS and the exacerbations were lower in that group, and asthma control was much better in that group. So this is how, FENO can be used. We can use FENO to monitor the airway inflammation. So if, I'll give you an example, you have a FENO baseline level, you start the treatment, you diagnose the patient of asthma, you start them with the treatment, and then at 3 or 6 months of follow-up, when the patient is coming to you, you do a FENO again. Patient is saying, I'm doing good, or maybe I'm not doing good and FENO values are still high, they do not decline. Then one thing which should come into mind is the poor adherence to the ICS, what the patient is taking, or the ICS doses are inadequate. So this will help you and guide the treatment. Sometimes you may see that despite high dose treatment, despite giving maximum treatment, the FENO levels are still high. So which just suggests that it is severe type 2 inflammation, though the incidences are low, but you should think about other coexisting diseases like chronic eosinophilic pneumonia or eosinophilic granulomatosis. If you look at this graph, it's interesting. We should know that. So if you look at this graph, it shows that FENO values decline faster after starting the treatment, even before the symptoms, or if there is reduction in the symptoms or airflow obstruction or airway hyperresponsiveness, right? But that doesn't mean that just based on FENO, we should step down our treatment. It should be looked overall, and we should combine all the parameters together. Again, another clinical utility of FENO is to assess the suitability and predict the response to biologics. So when do we decide that the patient goes for biologics? You have a patient, you have given maximum treatment, still patient continues to use high dose of ICS, you're unable to step them down, or the patient requires short courses of OCS or low dose of oral corticosteroids to keep the asthma under control. So basically we are talking about patients who are difficult to control or who have severe asthma. What is one thing which you would like to do in these patients before you consider them to go for biologics? One thing, you rule out that the patient is adhering properly to the treatment or not, which is very, very important. 70 to 80% of the times when the patient comes and we say that it is uncontrolled or difficult to control asthma, please look at how the patient is taking the drugs and what drugs he is taking. That may be the reason, and you may just modify that, just correct that, and patient will have control over their asthma. And also to assess the type 2 response. FENO as a biomarker has shown predicting, it can predict enhanced treatment response in moderate to severe asthmatics when they have an eosinophilic phenotype, which is not controlled with IC or OCS. So a cutoff for FENO for omalizumab has been given as more than 19.5 parts per billion, and for dupilumab, it is more than 25. Tezepelumab is another, another biologic which has come. It not only just talks about the FENO, it shows simultaneous reduction in FENO as well as blood eosinophil and IG all together. So it probably suppresses the multiple inflammatory pathways. So it is in phase 3. I'm not sure it is available in India at the moment. Let's come to the more clinical thing, what is of interest to us. So we know that FENO is useful, particularly in asthma, in supporting the diagnosis where there is difficulty, in monitoring, and probably help in deciding the treatment up and down. What are the guidelines we talk of? There are various guidelines. They have put up different cutoffs, simply probably because there is variation in how it is measured, and in various conditions as well. The most sought out one is the ATS criteria, where high FENO is told as which is more than 50 parts per billion. And when we say that it is high FENO, it means, it indicates that the eosinophilic, it is probably an eosinophilic, it is most likely eosinophilic inflammation, and in symptomatic patient, responsiveness to corticosteroid is very, very likely. When you have low, which is considered as cutoff of less than 25 parts per billion, it means that the eosinophilic inflammation and responsiveness to ICS is less likely, and this is a real strong recommendation. When you have intermediate values between 25 and 50 parts per billion, then you have to correlate clinically. You have to see into the clinical context with whether the patient history is suggestive, all, and then you take into account. Again, it will depend whether the patient is on treatment or at first time he is presenting to us. So it should be interpreted cautiously and in clinical context when your FENO values are between 25 to 50. Again, is a single value important? Yes, single value at a baseline is important, but changes in FENO over the time are also very important, and when we have serial FENO measurements, then it should always be compared with the previous measurements. Then how would I say that the patient is improving based on FENO, or patient is not improving with the treatment what I am giving to the patient? So the cutoff has been given as if the baseline FENO was more than 50 parts per billion, then an increase or a decrease of more than 20% would say whether this patient is improving or not improving. Certainly reduction means patient is improving to the treatment, and if there is an increase, that means there is worsening of the airway inflammation. If the patient has a baseline FENO of less than 50 parts per billion, then the cutoff is taken as more than 10 parts per billion from the baseline value, right? You got it? Understood? So 20% if FENO is more than 50, and more than 10 or less than 10 if FENO is less than 50. Those are the cutoff to define the improvement or no improvement or worsening. Sorry. I would like to spend some time on this one, because this is how we are going to interpret FENO in our clinical practice. So you have 3 columns, less than 25, 25 to 50, and then more than 50, and then on your right side, you have 3 columns again, symptoms present. So this is at the time of diagnosis when the patient is presenting to you with the symptoms suggestive of asthma, say cough, breathing difficulty, wheeze, or any of those symptoms. If the FENO at that point of time is less than 25, then eosinophilic airway inflammation is unlikely. Patient is unlikely to benefit from ICS. Please think alternative diagnosis. If it is 25 to 50, as I said earlier, be cautious. Look into the clinical context, and still you can make a diagnosis of asthma. But when you are doing it, monitor the change in FENO over time when the patient comes to you for follow-up. But if FENO is more than 50, then you are very sure that this is an eosinophilic airway inflammation, and the patient is very much likely to benefit from ICS. So this is at the time of diagnosis. Now then we come when the patient is coming to us during the follow-up. We look at clinical, right? Whether the patient is symptomatic or not symptomatic. So I have a patient who comes, who says the symptoms are present. We take that group first. Symptoms are present. I did a FENO, and it is less than 25. Symptomatic, FENO is low. We should think about a possible alternate diagnosis. This patient is unlikely to benefit from increase in ICS if he was taking earlier. If it is 25 to 50 and still patient is symptomatic, then we have to rule out whether there is persistent allergen exposure is there, or the dose of ICS which I have given, whether it is inadequate, probably I need to step up, or patient is not taking the drug properly. We have to look at the adherence. And at this point of time, we may think of maybe this is a case of steroid resistance, but I think the first three reasons may be more beneficial, and we should look into that. But if the patient continues to have high FENO and he's symptomatic, then certainly all these features come into effect, and we have to look into it. Now, these patients are certainly at higher risk of exacerbations, and we just need to look into what are the other ways we can bring symptoms control. If the patient comes to you in a follow-up where the symptoms are absent, he is all right, and the FENO is also come down, that means these are adequate ICS doses, patient is adhering to the therapy, at this point of time we can consider tapering the ICS dose, provided there is all clinical improvement and other things are fulfilling. If the FENO remains between 25 to 50, it still means whatever the doses we are giving of ICS is adequate, but probably this is not the time that we should step down the patient, right? So we'll monitor the change in FENO, again, call them again after 3 or 6 months. Now, small group of patients may be there who are on treatment, who are asymptomatic, but still have high FENO despite good asthma control. So this may result, this probably may result from the fact that more than one factor, not just the eosinophilic airway inflammation, is responsible for the elevated FENO. And then, so sometimes levels greater than 50 parts per billion in a well-treated asymptomatic, there are the two terms, well-treated and asymptomatic patients may be normal for that specific patient, but needs to be closely watched. Coming to what are the confounders, or what are the factors which can cause, false positive or false negative results when we are doing FENO. So at FENO levels are increased if there is concomitant presence of allergic rhinitis and atopy, and it is shown to increase the FENO levels by approximately 20%. Height and male sex is associated with higher FENO levels, and what could be the reason for that? Probably differences in the airway caliber and the surface area may be responsible for this observed variation for the male sex. And height, again they say it is height dependent increase in the total airway mucosal surface area that produces NO can be responsible for this. Then consumption of certain dietary nitrites like in caffeine, green leafy vegetables, lettuce, radishes, beetroot, certain of these, and even alcohol can cause increase in NO levels. FENO levels can be reduced. Reduced age, I mean, of course the age doesn't reduce, but what I meant to say is here is, I'm sorry, again there is some, yeah. What I meant to say was that in children, the FENO levels are less compared to the grown-ups. Smoking has an important effect. It decreases the FENO levels, and the causes could be reduced in the enzymatic activity of the NOS, or sometimes it is also proposed that tobacco smoke can contain higher concentration of superoxides, which react quickly with NO to produce active nitrogen species, and that may be the reason why it is reduced. And of course, when the patient is on steroid treatment, corticosteroids, the FENO levels can be reduced. How to measure? What is the device, right? FENO can be measured by spectroscopic electroanalytic sensors or laser-based methods, but the spectroscopic which we use is the chemiluminescence, and that is the most widely used, most easily available device and the method, and it is also considered as gold standard for gas phase NO analysis. The devices which are available in India, so I feel little, when I spoke to the people over here, I found there are so many other devices which are available, but what I have in my lab is, and what the vendor, when we were speaking to them, they suggested only two. So one is Neox-Vero, which has been there for past 20 years. They are the pioneer in FENO actually. And then there is Evernoa, which has come from Spain maybe a year ago only. Both these devices, and there are other devices, I'll show you the pictures which I have just downloaded yesterday night only when I was sitting here, but I'm not sure about their availability and what's the price and all. So these are the two instruments which I have in my lab. This is the Neox-Vero and this is the Evernoa. Both are very simple portable devices, battery operated. And taking a FENO test is as simple as inhaling and exhaling. There is no blood, no sweat, no tears. And what happens is you ask the patient, we will do it in the practical session of course. So you ask the patient to exhale out, and then this is the breathing handle which we are talking about. You patient puts the breathing handle in their mouth, then they inhale for 3 seconds, and then they exhale at a steady flow rate, which is at 50 milliliters per second. Now, you don't have to bother about that. There is enough animations and sounds depending on various devices, which will enable the patient to keep that flow steady. And once you have done that, 6 seconds for children and 10 seconds for adults. Once you have done that, it stops, wait for a minute. It takes a minute for the machine to analyze, and you get your report. This is how Evernoa will work, where you have this animation and the patient, it will tell you are doing good. It's just an animation, and once you are finished your 10 seconds, this will stop. As simple as that. Because I was also told to tell about which device we should purchase. So I wanted to say there is no conflict of interest in any of the machines. I have both the machines. So between the Neox and Evernoa, there's a single study, 196 patients, and when they compared, they found that the correlation between the measurements with both the devices as well as the concordance was excellent between both the devices. However, there was patients did say that the ease of use was little better and the reproducibility was little better with Evernoa. Coming to the cost of the device, so I'm not sure how does it works, but at CMC they give us the machine is free of cost for us, and we have to buy the cartridges only. So I know the cost of the cartridges. For Neox, it is 3 lakh for 300 cartridges, and for Evernoa, it is 1.8 lakh for 400 cartridges test, if you would say. So that is between 1,000 versus 450 rupees. That is how it is there. So you can decide. We are finding difficulty in procuring the Neox cartridges. I think experts may tell us if they are facing the same problem, but we were using it for we have been using Neox earlier, and now recently we have started Evernoa. And this is again, you know, another one which is present. I saw this, I put this picture from India Mart, which is available. When I was sitting down, I saw the Yashoda is showing this. So I thought this is the one which they have it. This is called as Enobreath bed font from UK. I'm not sure whether it is available, but on India Mart, it shows it is available. The cost is 5 lakh rupees. Coming to the format, the report format. Now, if you look at this on the left side, this is one of the reports which is from one of the hospitals they are doing. The patient came to us. So it gives you, you know, the value and 10 seconds or 6 seconds. What I would say is this is not only, this alone is not important. While reporting FENO results, a minimum information should be included, which is what I have delineated. The date, time of the day, which is mentioned here, age, sex, ethnicity, height, smoking status, reason why do I want to do the test, prior diagnosis if known, and whether or not the patient was using inhaled or oral corticosteroid at the time of testing. Now, it is very important because we know there are quite a bit of confounders for measurement of FENO. So please make sure that you do add in your report. What is important to know? That avoid smoking prior to test. Of course, we know why. Refrain from eating or drinking or exercise at least 1 hour prior to the test for the reasons we know, because certain drinks and certain food can cause increase in the FENO. Now, respiratory infections by viruses and bacteria have been reported to cause acute increase in the FENO value, which decreases during the recovery phase. So if you are assuming that worsening in the respiratory symptoms could be because of infection, then it is desirable to measure FENO after the infection has resolved. Again, important thing, when should I do? People were talking about when we should do IOS and then Spiro, lung volume and DLCO. The same comes when I should do FENO if I have to do both the things together. And of course, we have to do both the things together. So it is shown that FENO is, FENO concentrations are reduced following forced expiratory maneuver in spirometry, and they take approximately 1 hour to recover. So for that reason, it is advisable to do FENO before doing spirometry. Now, this effect of a spirometry or FENO is less, but it is significant. And in studies, it had shown that mean fall is approximately 13% in healthy subjects and about 10% in asthmatic. And of course, before labeling the patient as non-Th2 inflammation, at least 3 measurements of FENO should be done if you are using that as one of the criteria to be label that patient as non-Th2 inflammation, not a single value. FENO in other respiratory diseases, COPD, people have talked. So it may be useful biomarker to identify the individuals who may respond to inhaled corticosteroid or to find out the patients who have an overlap with asthma. There's a single study about bronchiolitis obliterans syndrome, and they found that regular measurements of FENO following lung transplantation is effective in predicting the onset of BOS with a cutoff of 10 parts per billion or more. Again, needs to be more into the research. Other application, there is nasal NO and there is alveolar NO. When we talk about the nasal NO, this is a simple, same device like Neox has it. You have the nasal cannula, you put it up, and this has been established and mentioned in various guidelines as a screening test for primary ciliary dyskinesia before we subject the patient for more invasive testing like electron microscopy, taking the biopsies and subjecting them for electron microscopy. Levels below 77 nanoliters per minute is highly suggestive of PCD. Alveolar NO, a little bit, I think I'm overshooting, but I wanted to because we have time. Other speakers were kind enough to finish it well before in time, so we have little time. Alveolar NO, so people are now interested to find out whether, when we talk about the FENO at 50 ml per second, this gives you an idea of the bronchial epithelium, the bronchial evolution, or of more of the central airways. Now, people are interested to know whether we can find out with this NO measurements, whether it is useful to find out the peripheral, distal, or whatever you say, the smaller airways. And so what they try to do is they have tried to do FENO measurements at different flow rates ranging from 100 to 300 mils per second. And in few of the studies for COPD, they said that if you do FENO at 200 mils per second, then you can get an idea of the smaller airway, particularly useful in COPDs or even in asthma. And that may be, a concern when we are looking at the alveoli level and all those, whether it could help in somehow quantify or diagnose lung fibrosis. But again, more research is needed before we can use widely in clinical practice. Case scenario 1, we have a 45-year-old male with established asthma who present to us on follow-up after 3 months. He also has allergic rhinitis, positive skin test at that time of time to several aeroallergens. He is on medium dose ICS and LABA, and clinical history suggests good control. When they came to the patients, clinically he is good. I need to have an objective measurement. On current evaluation, examination is unremarkable and spirometry is normal with FEV1 of 98% predicted. Question is, should his therapy be stepped down? Anyone the takers? Can we do that? Probably yes, isn't it? We can do that. But we did a FENO and it was 77 parts per billion. So his asthma appears to be well controlled and stable functionally because we did a spirometry as well as clinically. But based on his FENO, it seems that his airway inflammation is not controlled. Now what will happen if we try to step down at this point of time? We know that the airway inflammation is still uncontrolled. If we try to step down, then this patient may come up with a flare-up or an exacerbation. He is at increased risk of developing exacerbation. So if I give you another value, FENO at 3 months at the time of diagnosis was 24 parts per billion. Does this make any sense? Does it helps you to explore something more? Whether in few days, okay, that's a good one. Anything else we can say? So we explored further and we asked, see, you were having a reasonable FENO, now it has increased. Your symptoms you are saying, so symptoms wise he was saying that he is well controlled. So allergic rhinitis symptoms are not worsened. So when we explored further and asked, sorry? Right, so that was what we did, and when we explored, we find out that for last 3 or 4 weeks, the patient is not regular in taking his inhaled corticosteroid doses. Adherence, he was taking only for 2 or 3 times a month. So at this point of time now, if we have a FENO value, we are more intelligent, and we would rather stepping down just based on spiro and clinical history, we would ask him to use his drugs regularly and probably call him at 2 to 6 weeks time to measure again what is the FENO, to be confident that airway inflammation is taken. So after 3 weeks, it was 23 parts per billion. So case scenario 2, 53, sorry. Okay, just one more or shall I just skip it? All right, so 53-year-old female present for the first time with chronic cough and possible wheeze on and off for the past year, especially with the exercise. Relevant history is she's been using cough medications of various types which have not helped, and there is a significant history of GRD that apparently has worsened over the past years, but she has been taking omeprazole. Current evaluation, physical examination is unremarkable, skin test for atopia negatives, chest x-ray is normal, ENT evaluation doesn't show anything significant except the usual what they put is as laryngopharyngeal reflux. Spirometry is again normal, FEV1 is 101% predicted. What is the diagnosis? Sorry? Yes, one of the diagnoses could be cough variant asthma, and how would I confirm it? How would I say? Patient is giving a history that he has GRD, which has worsened over 1 year. So could that be the only reason which is caused? So before I refer the patient to gastro specialist, gastro colleague to find out if that is the only reason, probably we did an FENO, and FENO was very, very high, which is in favor of significant eosinophilic airway inflammation. So although she has symptoms of GRD and she's been using omeprazole, but in this patient, we gave a trial of inhaled corticosteroid and it resolved the respiratory symptoms. So I'll skip the case 3. And so FENO, if you ask me, where do I place it in my clinical practice? For difficult to diagnose cases where you have the history and is very much suggestive of, asthma, but all objective measurements which we have in our armamentarium is all normal. Probably that it may help as a baseline for asthma, for stepping down and step up in asthma, and for assessment of difficult to treat or severe asthma, specifically to look at the adherence. So it is a quantitative, non-invasive, simple, safe, and point-of-care test which complements the clinical assessment and other objective tests, but further research is needed to identify its role in other respiratory disease and the cost effectiveness in clinical practice. Thank you so much. So.
Ma'am, among the factors which you mentioned as affecting NO estimations,
right, sir.
One which is not explored much is the effect of ambient air pollution.
Right, sir.
That makes a tremendous difference. In
It
fact,
will.
it's a marker of exposure to air pollution.
Exactly.
In our scenarios, I don't think anybody has worked out how much our levels of air pollution affect, whether we follow the same levels of cutoffs or our levels should be different.
That's true, very true, sir, because NO, as far we have known before 90s or so, we were using it as a pollutant, something which has been causing pollution. This is a very good research thing, and we should explore, and probably our numbers will be little more depending on which side we are, probably in the north of India or the south of the India.
One more comment.
Right.
Gina is a bit reluctant to recommend use of
FENO,
both for diagnosis and monitoring.
Correct, sir.
So your first indication is okay for difficult cases where you're not sure, but it cannot be passed on as or established as a general test for workup in an asthmatic.
Certainly not, sir. Certainly not. So as I'm saying, it is just complementing to the other objective measurements. It is not the only test to make a diagnosis of asthma.
Thank you, madam. The next speaker is Dr. Vishwanath.
Okay. We can discuss this. Sure. Thank you.
He's a consultant chest physician and interventional pulmonologist at AAG Hospital, Hyderabad. And he has been very instrumental in setting up the first ever e-bus program in 2013 in the twin states of Telangana and Andhra Pradesh. He has national international publications and written many chapters in textbooks. And also has been a team member for formulation of NCCP and Indian Chest Society guidelines for diagnosis and treatment of HAP and VAP. So he will be delivering his talk on 6-minute walk test, indications, technical standards, and clinical interpretations. Over to Vishwanath.
Thank you, chairpersons, for the kind words of introduction. Respected senior pulmonologists who are present here, and my dear colleagues. Very good afternoon to all of you. At the outset, I would like to thank Dr. Nagarjuna and his entire organizing team for giving me this opportunity to share my thoughts and views on 6-minute walk test. 6-minute walk test is not something very new test which has come up actually. It's a very old test which has been commonly practiced by a lot of us in our clinics. However, during the COVID times, this test also has become popular among non-pulmonologists to detect early deterioration and the possibility of predicting an occult hypoxemia. Though it's a very simple and inexpensive test, a lot of times it's not practiced even amongst our pulmonary colleagues also because of various reasons like lack of awareness regarding the utility of the test, and also regarding the because of lack of availability of the 30-meter corridor which is needed for performing this test, and sometimes the financial incentives. Suppose if you do an spirometry in any of the hospital, anywhere it would cost between 700 to 1,000 rupees, or if you do a further test, they're costly. But the 6-minute walk test cannot be charged more than maybe 300 or 400 rupees. So there are many other reasons why a 6-minute walk test is not being performed. So in the next few minutes, I will be discussing about what is 6-minute walk test, different technical considerations, how to perform the test, and what are the caveats, and how to interpret the test. As we know, there are numerous exercise tests which are available. like cardiopulmonary exercise testing, a 6-minute walk test, a shuttle walk test. There are numerous things. But this is one of the most commonly performed exercise tests. The reason being, it's it can be performed in any setup without any much equipment. So it's a self-paced test, meaning to say that the patient decides his own pace, and also the patient, if he develops any breathlessness or fatigue during the test, the patient can stop for a while and restart the test during the test. And most often, the patients achieve an submaximal exercise capacity. They cannot reach their maximum exercise capacity. As we know that most of the activities of our daily living are performed at the submaximal exercise capacity level. So 6-minute walk test actually predicts or actually reflects more often the person's ability to perform his daily activities of living rather than any other test. There are different technical guidelines, but however, this is one guideline which has come up from American Thoracic Society in 2002, which has dealt up in detail about the different considerations and technical specification for this test. Now let us understand what are the different indications for doing this 6-minute walk test. So commonly it's done as a test to determine the pre and post treatment response. You have put a patient on treatment for COPD, interstitial lung disease. You have done a surgical procedure like lung transplantation, lung volume reduction surgery. So if you want to assess the effect of this particular surgery or the therapy on the patient, you do this 6-minute walk test. And the other common indication is to assess the prognosis of a patient and assess the functional status of the patient. You do a single time in COPD patients, heart failure and cystic fibrosis and numerous other conditions. And baseline 6-minute walk test indicates the prognosis and also the probability of the patient dying in the next few years or the patient doing well in the next few years. And it's also a predictor of mortality in patients who have heart failure and primary pulmonary hypertension. In the clinical practice, I also use it in most of the clinicians, senior pulmonologists also use it as a subtle pointer to differentiate between breathlessness of pulmonary versus the cardiac origin. So I would like to share a simple case story, but very interesting case story. We had a patient a few years ago, 32-year-old male patient, was a software employee. He presented with recent onset of breathlessness and climbing stairs and no other symptoms, no chest pain, no cough, nothing. There was no previous cardiac or any pulmonary issues. The patient was previously healthy, but has a sedentary lifestyle and was going through work stress. He is basically trying to meet a deadline for a project actually. He was very anxious. So because of his breathlessness, which is of recent onset, he went to a cardiologist. So cardiologist, he did a routine evaluation. The ECG showed sinus rhythm. The echo was done, which showed a normal LV function, and also showed a normal cardiac chambers. So treadmill test was asked to be done. However, the patient could not do beyond stage 2 or stage 3 Bruce protocol of the treadmill test. And he did an X-ray also, which is not the usual case. They probably would say that the chest examination is normal and they would stop there. But here this patient underwent chest X-ray also, which was normal. So since this patient's breathlessness was not improving, the patient was referred to a pulmonologist to evaluate possible pulmonary causes. So on clinical examination, basically he did not have any V's, no pallor was there, his renal functions tests were normal and hemoglobin was normal. So what are your possibilities at this point of time? Any guesses? I would like the young pulmonologist to take guess. Breathlessness, cardiac evaluation normal, and a chest X-ray which is normal. What? He was going through anxiety, remember that. So he was basically labeled as anxiety-related breathlessness. Would you agree with this, or would you want to do further evaluation for this patient? Further evaluation, what would you like to do for this patient? I would actually do a D-dimer for this patient. D-dimer and see whether this patient has a pretest probability of at least it has a very good negative predictive test value. But however, I did not do D-dimer for this patient. I thought the 6-minute walk test is easily available and it can be done in a duration of 5 to 6 minutes. So surprisingly, we found that there was an exercise limitation. There was, the 6-minute walk distance was 220 meters, and there was significant desaturation. As you can see that the saturation dropped from 95% to 86%. And there was the resting heart rate was on the slightly on the higher side, and there was an increase in the heart rate after the 6-minute walk test. The blood pressure was stable after the 6-minute walk test. So I felt that this chest X-ray was normal, chest examination was clear, there was a resting, there was exertional tachycardia and desaturation. So my possibility at this point of time was pulmonary thromboembolism. So I did not do a D-dimer, I directly did an CT pulmonary angio in this patient, and the patient turned out to be having an pulmonary embolism. The story later is that the patient had an increasing breathlessness post the test. Actually, he landed up in emergency. Actually, he had an hypoxemia. Then patient had to be thrombolized. So a simple test actually could help us in differentiating whether the patient's breathlessness was really an anxiety-related breathlessness versus a cardiac cause. So often before in your clinic, before you label them as having an anxiety-related breathlessness, you do a simple 6-minute walk test and see whether the patient is having any desaturation. Only in pulmonary diseases you have desaturation after walk test actually. In cardiac diseases, they might have an increase in the heart rate, they might have an increase in the blood pressure, which indicates that the patient might be having a diastolic heart failure or a diastolic dysfunction. However, if there is a desaturation, the only cause could be a pulmonary cause. So you look for any cause of pulmonary parenchymal disease or an pulmonary vascular etiology. So now let us look at some of the important contraindications before you do this test. The absolute contraindications are the patient had an unstable angina or myocardial infarction within the previous month, or if the patient's heart rate is more than 120 per minute, or if the patient's systolic blood pressure is more than 180, or the diastolic blood pressure is more than 120 millimeters of mercury, you should not be doing the 6-minute walk test for this patient. Or if the patient is experiencing any active symptoms like active chest pain, active breathlessness, or patient is having a pre-syncope or giddiness, this is not the patient in whom you will be doing an 6-minute walk test. And there are certain safety issues to be kept in mind when you're doing an 6-minute walk test. So it should be performed in an area where the response to an emergency is there. Suppose if the patient develops any kind of desaturation or develops a chest pain or any breathlessness, at least there should be some people around who can immediately respond. There should be a code blue team if you're performing it in your hospital actually. If there is any eventuality which can happen during this test, most often it has been proved beyond doubt on lakhs of 6-minute walk tests, it's very safe. But sometimes we see in our clinical practice that patients develop, especially when we are not choosing the right patient. And the patient is already very sick and you are doing a 6-minute walk test in this patient. These are the patients who can actually deteriorate. And they should have a crash cart around yourself to see whether everything is available, especially in case of any eventuality. Your technician who is performing the 6-minute walk test should be at least trained in BLS. It's best if the patient can also be trained in advanced cardiac life support, but at least in BLS, the patient should be trained in that. And the physician need not be present at the site actually. So since it's a safe test, except barring a few occasions when you're doing it in very sick patients. And if the patient is already taking a long-term oxygen therapy, continue the long-term oxygen therapy when the patient is, if the patient is on it. Suppose if the patient is on say 2 liters of oxygen, continue that, or for the patient's comfort, you might prefer to increase it, especially when the patient complains of breathlessness. If the patient during the test, if he complains that he is developing diaphoresis, chest pain, staggering of gait, or any kind of giddiness, you need to stop the patient, you need to stop the patient from doing the 6-minute walk test further, make the patient sit where he is, or you can ask the patient to lean to a wall, whichever wall is there by the side, and then the patient can be asked to restart the test once he is comfortable. Suppose if the patient is not comfortable to restart the test, then probably you can abort the test. You can note the reason for aborting the test and then stop the test there. So the patient preparation for this 6-minute walk test, the patient should be wearing a comfortable dressing, should be wearing his comfortable shoes especially, or if the patient uses a walking stick or cane while walking, the patient can be using these walking sticks during the test. And the patient can take the usual medications, and the patient should have come to you after taking a light meal to avoid any kind of giddiness during the test actually. So light meal is preferred. And the patient should not have exercised vigorously within 2 hours of beginning the test. It is said that if you do a vigorous exercise, the patient goes into a state of fatigue, and your 6-minute walk test may not give you accurately the 6-minute walk distance. So the patient should not be doing any vigorous exercise before the test. And some of the basic equipment which is required during the test are a countdown timer, which is available most of us in our mobiles these days, and like a mechanical lap counter. You don't have to buy a separate mechanical lap counter. You know that in our timer we have a lap counter. You can count the laps using your mobile, and you can put 2 red tapes or a small cones to mark the turnaround points around the 30-meter strip actually. And a chair which can be easily moved along the walking course actually you need to have. In case the patient develops any kind of breathlessness, the patient can be made to immediately sit. So you need to have some like a sheet which is already filled with the basic details, sphygmomanometer which can be used to measure the blood pressure. And again, in hospitals where there is a facility, probably you can have an automatic electronic defibrillator, but it is not must to have the electronic defibrillator for this. And the other technical aspects which are required for this specific test are you require an indoor flat corridor which is of 30 meter and which is hard actually. If the climate is present, probably the patient can do the test outdoors as well, but most of us prefer to do it in the indoors actually, in a 30 meter or a 100 feet length corridor. And the corridor is marked at every 3 meters with a small red tape for you to understand how many meters the patient has walked, if in case he is not able to complete the full lap. And as I told you, the turnaround points are marked with a cone. And there are test studies which have done with a shorter corridors also. Most of the studies they have used a 30 meter or the 100 feet corridor. However, there are studies which have used a 20 meter corridor or 50 meter corridors. In a smaller length corridors, the patient has to walk more number of laps, and the patient will probably waste more time in taking turnaround actually. It was found that if you are using a smaller corridor for doing the test, smaller than 30 meters, so at least their 6-minute walk distance reduces by 14%, the 6-minute walk distance. So ideally, it's better to have a 30 meter distance, but if still you are not able to have, probably you can have whichever length you have it. So as for certain tests, a warm-up session is not actually recommended. It is said that if you are asking the patient to do a warm-up test, it actually reduces the 6-minute walk distance. So ideally, the patient should be seated in a chair which is very closer to the 6-minute walk distance start point for 10 minutes before starting the test actually. So these 10 minutes of time, the patient is taking rest. You should be utilizing it to check the patient's baseline vitals, heart rate, blood pressure, and the saturation. Explain the patient about the test actually. Most often these patients are all deconditioned. Most of us do not, when you're in a physically good shape actually, we don't mind about doing 6-minute walk test, running or jogging actually. But these patients are, mind you, that they're very, very deconditioned actually. They're very hesitant to do even a 6-minute walk test also. Just reassure them that this test is going to be simple. You're going to be, along with the patient, the technician, whoever is doing the test should be there will be available along with the test. And then you can also tell the patient that he has the, he can choose his own pace, and also he can sit or stand and take support when he has any active symptoms which are going. And there is no need of constant monitoring of saturation during the exercise. So most of the finger pulse oximeters have motion artifacts. So if you try to check the saturation during the 6-minute walk test, it most often gives you an erroneous result actually. So it is recommended to check the saturation just before the test and at the end of the test after the 6-minute walk test. You don't have to check it while the test is going on. Just similarly, the heart rate and blood pressure also measured just before and after the 6-minute walk test. So the technician need not keep a note of this saturation SpO2 probe. And one important caution is that since this finger pulse oximeter have lot of motion artifacts, when you're checking the saturation with the finger pulse oximeter actually, you check whether the waveform is good, whether the signal is good or not. Then check the saturation. Lot of times, COVID times, we have seen that patient's pulse oximeter was run out of the battery. It was showing low saturation, and the signal never used to be so good. So looking at this lot of problems, actually, we have shifted to using medical monitors when we are doing 6-minute walk test. 6-minute walk test, the medical monitors like Philips monitors are different company monitors which are used for checking the vitals. The same monitors we are using for checking the saturation also. So they don't have this so much of finger artifact and the motion artifacts. So the parameters which are measured during the 6-minute walk test are the distance. That is the most important parameter which is measured. The baseline oxygen saturation, heart rate, and the blood pressure, and the box scale. So the patient is given a scale which shows an severity from 0 to 10, like starting from nothing to a very severe scale. The patient is asked to note his baseline box scale of breathlessness and the baseline box scale of fatigue. So this box scale is noted before the test and also at the end of the test. And you have this basic template which is available in the ATS document. You can also prepare your own document, so which contains all the demographic parameters, the what is the disease, the basic age, height, weight, and the baseline heart rate, vitals, and also the 6-minute walk at the end of the test, what are the parameters to be noted. So if the patient is noting for any reason at the end of the 6-minute walk test, what is the reason for pausing should also be noted in this thing. And the number of laps, if you have an, as you can see here, the number of laps here should also be noted. So it's, if you have an 30-meter lap, then you can note into 60 meter how many laps. So in our earlier unit, we used to have a 25-meter lap actually. So we used to note it as into 50 meters. Now we have a 30-meter lap actually. So the total distance, walked in distance, should also be noted. And also we have certain equations to predict what is the predicted value of 6-minute walk distance for a particular age and sex actually. So we have equations available from the Western countries and also equations available from the Indians as well actually. So you can know the predicted distance in meters and also the percentage of predictors. Most often actually I would like to compare the patient's baseline 6-minute walk distance with the 6-minute walk distance which is performed later on. That gives us whether the patient is improving or not. Because probably in India also there are only a couple of studies which have looked at the predicted values actually. Not much data actually, even though there is some data. So these are the things to be filled when you are doing the test actually. So there are some standard precautions which are to be given to the patient actually. And you should tell the patient that the patient can walk in a comfortable pace, and the aim is to walk as much distance as possible without getting strained or fatigued. And you can tell that the patient has to walk briskly around the cones actually. You should not be stopping at the cones. Most often the patient becomes hesitant and takes longer time to come back actually for the return lap. So you just tell them you walk a lap along, before you ask the patient to start doing the 6-minute walk test. Let the patient see how you are walking, how you are negotiating the cone back and coming back. And then you ask the patient to start walking it. So when the test is going on, actually, so each minute you need to tell the patient saying that you have done a good job. See, you have completed the 1 minute. There are 5 more minutes to go. And then with each and every passing minute, you need to update the patient that you are doing well, and then the remaining time, what is the remaining time which is available for the patient with the test. So when you are about to complete the test, when you are about probably say 15 seconds or 20 seconds about to complete the test, then you say that in a while I'm going to tell you to stop doing the test, and that is when you need to stop immediately when I need to tell you. So the patient might not have completed a full lap. However, you can see you can note that the patient would have done maybe 6 laps and then say another 15 meters distance actually. You can, as I told you, you mark and 3 meters distance in the corridor, in the 30-meter corridor. So you can know how many meters the patient, additional meters the patient has walked in addition to the laps which he has completed. So earlier, I was telling you that we were using the finger pulse oximeters to check the baseline saturation and heart rate and the blood pressure. However, with this lot of artifacts, we have shifted to medical monitor, and subsequently now, when we upgraded our pulmonary function testing laboratory, we have started using this Winter's Walk. Winter's Walk, basically it contains an small monitor, which has a finger pulse oximeter, which can be attached to the patient's finger. You don't have to ask the patient to hold it by the finger actually. And then there is a tab actually, so which will keep on reflecting. You need to, in this tab, there is a template where you enter the demographic and also the baseline details. And here, the patient's saturation is directly via Bluetooth is getting reflected. There is no need of actually checking the saturation. However, the test can actually, this equipment can tell you what is the saturation the patient is having while the test is going on also. So this is how the equipment looks actually, the monitor and the saturation and this monitor. And we need to, so this is the procedure. I'll just show you through a brief video as to how the procedure has to be done, because it's going to be very, very important when you start doing the 6-minute walk test. All the precautions to have to be taken when doing the test actually. In fact, a lot of times, even when we started doing the test also, we are not following some of the things. When we reviewed the literature and saw that we were not following certain of these things, then we changed our technique of acquiring the data and doing the test, and the way we instruct the technicians also. That's all going to be very, very important actually. So these are our technicians. Have taken permission to show their photos actually, or faces. So we have applied the Winters walk for this, and also checking for yours. We are using a medical monitor here to check the patient's baseline monitor. So we believe in mostly the medical monitors because the errors are less. Even if you don't have Winters walk, the fancy gadgets, it's okay. But at least a medical monitor is good enough to check the baseline vitals very well. So once you have checked the vitals, you need to ask the patient to sit at rest for 10 minutes and take this opportunity to explain the patient about the test before this test is done, and also check the baseline vitals and also the baseline box scaling. And this is the 30-minute corridor which we have, in which the patient actually walks. So as I told you, this is our technician who is taking the patient actually. As you can see that the technician has to stand behind the patient. You can also probably stand by the side if you have adequate space. However, it's advisable to stand behind the patient and see whether the patient is staggering, developing any symptoms, and also reassure and keep encouraging the patient when the patient is doing the test. So the patient walks back and forth on this 30-meter corridor. So, and then at the end of the test, you note how many laps the patient has walked, and also the distance which is walked, and also again note the vitals at the end of the test. So this is our basic format which we used to follow since long actually, because to keep it very simple, we kept only the obvious parameters which are required for the patient actually. The box score, you can see heart rate, BP, saturation, and also the distant walked actually. So a 3% drop in the saturation is actually considered as significant drop in saturation. So suppose if there is a drop in saturation of say 2%, that is not considered as significant. 3% or more is considered as a significant drop in saturation. However, with the new equipment which we have actually is a very complicated template. We have asked the company people to change the template actually to a simpler one actually. So that is a problem which other people who are using this also have expressed actually. But the only good thing about this is actually we have the parameters at each and every minute actually, if in case we want to know after how many minutes the patient is actually desaturation. And also it also gives us the heart rate and this thing. Again, the blood pressure has to be manually monitored and entered into the system actually. So it measures the 6-minute walk distance. So a little bit of automation is there, but it's not required. A simple medical monitor, and then you can count the laps, and also the distance walk should be fine. So in case if you don't have a 6-minute walk test, and if you find that a 6-minute walk test is not possible in your setting, there are other tests which are called as an incremental shuttle walk test, which uses a smaller course actually, which uses a 10-meter walk course where the patient walks back and forth. In this actually the patient is given an audio signal from a tape cassette to direct the walking pace. The walking speed is increased every minute. The patient is asked to walk speeder and every minute. The test ends when the patient cannot reach the turnaround point within the required time. So the advantage is that it has a better correlation with the peak oxygen requirement compared to the 6-minute walk distance. However, the disadvantage is that is not very well validated, not many studies, and used less commonly. But again, more potential for cardiovascular problems, because when you're asking the patient to walk fast, sometimes the patient might become anxious because he's not able to walk faster. There is a chance that patient might experience chest discomfort, especially in a cardiac patient. So I feel that the 6-minute walk test is more practical than any other test to do, especially in the exercise testing. And there are other tests like 5-meter testing, which is used for congestive heart failure patients, use of accelerometer, which are given in the literature. However, we have not used these tests. And this is one test which I found very interesting actually. A 6-minute stepper actually, so you don't need any corridor, but however, there is a stepper actually where you need to just keep on stepping on it. Actually, the patient, the stepper will actually count how many steps you have put actually. This has again not been validated, but there are studies in like patients with interstitial lung disease and also in sarcoidosis, and it has been shown to correlate well with the 6-minute walk test also. So somebody wants to have a fancy test, probably you can use a stepper test actually, 6-minute walk test. No corridor required, just the patient you can put it by the side of a wall, and if the patient feels that he's getting fatigue, probably he can lean to the wall and then restart the test actually. And again, in a sit-to-stand test, actually, this is also a simple test which is being validated in children, especially in patients with bronchiectasis. So a 30-minute sit-to-stand test, actually, repeated sitting and standing, has been shown to correlate well with the 6-minute walk test, actually. And you can do it in your outpatient chamber also, sit and stand. It's also the exercise testing. So as for the 6-minute walk test, this is the one which is given in the American Thoracic Society guidelines. However, we have the Indian predicted equations from Dr. Ramanathan from Coimbatore team. Actually, they have formed a predicted equation for the Indians actually on a small group of patients. And coming to the reproducibility and variability of the 6-minute walk test. So suppose if the patient has already done the 6-minute walk test earlier, then there's a chance that the patient does it better next time actually. So on the same day that you're repeating the patient's 6-minute walk test, you might find that the 6-minute walk test is better actually. So because the patient's understanding is better. So generally it is said that training will increase the intraday minimum variability by even more than 44 meters also. And the reproducibility is greatest when the patient's 6-minute walk test is done at the same time of the day. But often it becomes very difficult to call the patient at the same time of the day on the repeat visit actually. And it has been very well validated. And as you know that as the NYHA stage increases, the walking distance decreases, and it's inversely related. And the cardiopulmonary exercise testing also correlates well with the 6-minute walk test. You don't have to have an cardiopulmonary exercise testing to know the VO2 max actually. There are certain equations to predict what is the VO2 max of a patient from 6-minute walk distance. And it has been used to prescribe the exercise in patients who are undergoing pulmonary rehabilitation. That itself is a separate session, and did not want to get it into this talk actually. So the patients often reach the submaximal exercise, and the rate of perceived exertion, that is the Borg, it depends upon the heart rate, VO2 max, lactate level, and the ventilation. So for same patient of same age, sex, and this thing, same spirometry. So the perception of the Borg scale actually depends upon a lot of other things actually. There is previous exercise capacity, VO2 max, and a lot of other things. And just a few points on the safety. It's a very safe test, and there is no need for physicians, and just need to have a person who is trained in basic life support. Certain limitations of this test are that there is an ambiguity regarding the walking speed. The same patient sometimes may walk slower actually, but sometimes when the patient is motivated well, the patient might start walking better. So there are certain limitations, but I think you need to tell the patient to walk at the comfortable pace, which is more comfortable for him. And again, there are factors which affect the patient's 6-minute walk distance, and then suppose say the patient is taller, leaner, the patient's 6-minute walk test is going to be better compared to a person who is shorter and also who is obese. These things have to be kept in mind. And coming to different diseases, and there is enough data to show that 6-minute walk test actually predicts survival and also mortality in patients with congestive heart failure, pulmonary arterial hypertension, and also in lung diseases. A 6-minute walk distance less than 300 meters correlates well with mortality in congestive heart failure. And again, it has been correlated well with mortality in systolic heart failure. And even in stable patients with CAD also, it predicts mortality and morbidity. Even in respiratory diseases, in the European guidelines, we see that 6-minute walk distance more than 500 meters carries a very good prognosis. But whereas if a patient has a 6-minute walk distance which is less than 350 meters, it carries a poor prognosis. So, and it has been shown that use of inhaled corticosteroids in patients with COPD improved the 6-minute walk distance by 33 meters, and use of oxygen again during the 6-minute walk distance has shown to increase the 6-minute walk distance. And LVRS, lung volume reduction surgery, has shown to improve the 6-minute walk distance by approximately 55 meters or so. So again, in PAH, actually, there are numerous studies. even in PAH actually, the response to treatment is assessed by different parameters, symptomatic and like objective parameters. One of the parameters which has been used in lot of studies is the 6-minute walk distance. The minimal clinically important difference is noted as around 33 meters in patients with pulmonary arterial hypertension. So if a patient is improving by 30 meters in 6-minute walk distance, it's going to be very, very important. Coming to the last few slides, when to do 6-minute walk test. So basically the ERS and ESC guidelines say that the patient, whenever you are starting a patient on a treatment, so at baseline you need to do a 6-minute walk test. And again, after 3 to 4 months of treatment, you can do a 6-minute walk test to know whether there is improvement or not. And again, in stable patients, you can do it every 3 to 6 months in stable patients. As I told you, you can also predict the VO2 max by using certain equations in your patients. So concluding my talk, I would like to say that this 6-minute walk test is very simple, inexpensive to perform, and you require a basic equipment like a pulse oximeter or BP. You don't require a high-end equipment. Prepare the patient well, reassure them, explain them, and then take the patient for the 6-minute walk test. Capture the baseline data and also the parameters at the end of the 6-minute walk test. So the distance walked is the main outcome measured, and also the 3% saturation drop is considered as a significant. And it should be an important tool in your clinical practice for both prognostication and also assessing the response to treatment. In some cases, as I showed you in the case scenario which I've showed you, it also helps us in identifying what could be the possible cause of breathlessness. Helps you in differentiating whether the breathlessness is a cardiac or pulmonary related cause of desaturation. And it also helps us in rehabilitation programs, especially in giving the exercise prescription to the patient. And these are some of the references, and I thank you all for an patient listening. Thank you all. If there are any questions we can take now.
Thank you. I think we can take a couple of questions. We are already overshooting the time.
Yeah, yes, ma'am.
So if you don't have a 30-meter corridor, that is what is advisable, right? 30-meter corridor. Is it okay to have a 10-meter or 15-meter?
Yeah, I did cover that, ma'am. Actually, yeah. So good point,
Sorry.
actually. So most of the studies are actually done with the 30-meter corridor, and that has been very well validated. However, 20-meter corridor also has been in certain studies. However, the distance walked is almost 14% lesser. The reason being, again, the patient has to take more turns, actually.
Right.
So that is actually taking time and then reducing the distance. So probably if you have a 20-meter water, you are going to compare the patient's baseline value with the parameter which has done at the maybe at 3 months or 6 months. So I think the entire point is that the test should be done. Whatever corridor you have, actually 20 meters or so, you do the test actually. So you cannot have 30-meter corridor in all the setups actually.
Places, yes,
yeah. So I think the idea is to do the test actually, rather than saying that we don't have the corridor, we are not able to do.
So do we have any equations or anything to look for the change or incorporate that 14% or 13% loss which is happening?
So ma'am, actually the predicted distance you're saying?
Yeah.
So from Indian data we have from
No,
Ramanathan.
that we have. What I'm saying is about, so if you're using a 30-meter corridor, because which is the validated thing, and we have been doing with 30-meter corridor, but of late we are reorganizing, so now we are not getting the place, so we have been fighting. What I wanted to say, as you are saying, because the patient has to take turn, so some distance will lose. So do we have any correction equation for that or no?
So I'm not sure, ma'am, actually, but there was a 14% drop. Probably maybe you can factor in that 14% drop and you can say that, but probably there would have been equation also. The same
or maybe
thing
we can just do off one research to see.
Yes, yeah, maybe that's a very welcome suggestion actually. We can do it.
Thank you so much.
Vishwanath.
Yes, sir.
In a remote place where there is no PFT available or anything, a pulmonologist is there, the surgeon asks for pre-op evaluation. Can he go for a 6-minute walk test? Just for the sake of
See, most often before the pre-operative evaluation, what would you ask? You would ask the functional capacity of the patient. How many stairs would you climb? How much distance would you walk? What is your exercise? That actually does not give a real objective parameter because the patient's recall is actually variable. However, if you have a 6-minute walk distance, probably that is actually a very good predictor of the patient's functional capacity before going for an exercise. And there are studies which have been done on cardiopulmonary exercise testing, even on a 6-minute walk test also. It's good. Actually, if as a part of the pre-operative evaluation, before giving risk clearance, actually we can do this 6-minute walk test.
And can we roughly calculate the VO2 max from the 6-minute walk distance?
Yes, sir. Actually, there are there are some equations actually, because there is even the pulmonary rehabilitation also, because not all centers have the cardiopulmonary exercise testing. You can ask the patient to do 6-minute walk test, predict what is his VO2 max, what is his speed, and then you can give an exercise prescription based upon his target heart rate and which is achieving, and also the VO2 max.
Not many people have, if you're not able to do 6-minute walk test or thing, there is something called 1 minute sit to stand test. You
I did mention that 30 minutes sit to stand.
Sorry, yeah. So
yes, doctor.
1 minute, 1 minute sit to stand.
One of my patients is not ready for follow-up ILD patient for to see for improvement this for DLC or HRCT. Is it worth to do only 6-minute walk test?
Yeah, we do 6-minute walk test as a part of evaluation. Even in response assessment and nintedanib trials or pirfenidone trials, they actually check the 6-minute walk test and document improvement actually. It's an objective measure which is used in even clinical
We
trials.
can change the dose as per 6-minute follow-up test of doses.
So rather than changing the dose, we actually use it to assess the improvement of the patient actually. What is the distance walked and all this.
After 6 months, 6 months of treatment, if 6-minute walk test is deteriorating, should I change the treatment or increase the dose?
So actually, as you say, so the changing the upgrading the treatment, especially in ILDs, adding antifibrotics, the patient is already on steroid. There are so many parameters which we look at: forced vital capacity, DLCO, everything. So you have to take everything into consideration before upscaling the treatment, not just the 6-minute walk distance, because the patient's physical condition, the muscle weakness might have.
First visit, I am having predicted value, and what patient walk that value. After 6 months, that value is reduced, and oxygen is reduced.
But I think a minimum spirometry is required to actually upgrade your treatment. Just based on 6-minute walk test, you should not be.
Now
at least FEC will drop less than like more than 10% in the 6 months duration. Actually,
one 6-minute walk test machine of Cosmed is having all these things in that. Mask is there, and with that you can record FEV1 and everything. FEC.
Cosmed 6-minute walk test
with
equipment of Cosmed.
They have a mask for that.
So maybe they're checking the FEV1
I'm having
only.
that. Yeah. It's costly, 5 lakhs rupees.
So FEV1 would come by the forced exhalation maneuver. So are you asking the patient to do a forced exhalation maneuver during the 6-minute walk test? That we do not do. So I don't think actually it predicts the FEV1 when you're using even that equipment as well. So probably they have an inbuilt spirometer where you are actually checking an FEV1. That must be there.
What I am telling, my patient is not affordable. Every time he can do TLC and HRCT.
May I
Spirometry, you do spirometry free of cost.
May I add a comment here?
So
there is something called gap index for prognostication of the IPF patients. So that takes into account the physiological parameters, the 6-minute walk test and the spirometry.
Gender,
so
age.
Walk test is recommended to monitor these patients.
Yeah. If there are none, then I would like to conclude and thank you everyone for giving me this opportunity. Thank you for a patient listening. Thank you.
Thank you, Dr. Vishwanath. I think now we move on to the next thing on the list. That is inauguration of the advanced PFT lab. Ho gaya. Okay, sir.
Thank you, moderators and speakers, for this insightful session. Now we would disperse for 15 minutes tea break, and then we'll assemble back again for the session 3 CPET. Thank you.
Exactly. So open. You can connect this side also, no problem. You can detach it. Yes, it'll be much easier. Anything. That's good.
सारथी
आ गया?
हाँ ओके सर वर्किंग सपोर्टेड
सर आपके लिए चाय लाऊं? नहीं बस ज़रा मैं खुद बाहर निकलता हूँ अभी. Just I want to use washroom also. It's not coming there, no?
It will become sir.
Carmen Institute of Medical Sciences. He is also the organizing secretary of NAPCON 2023, the Silver Jubilee NAPCON. He piloted the airborne infection control guidance for India, drafted the daily regimen treatment for TB, and contributed to standards of TB care in India. He has several publications in national and international journals. I would also like to call upon stage Dr. Chetan Rao. He is consultant intervention and transplant pulmonologist, Yashoda Hospital, High Tech City. He has been awarded the Dr. Dheeraj Gupta Young Researcher Award at BronchoCon 2019 and Best Paper Award at BronchoCon 2018. May I request the moderators to call on the speakers, please?
Okay. Good afternoon. All good things always will come to an end. We are going for the end of this PFT Summit. The last two talks are before the lunch. This is, we have two speakers. One is Dr. Mateen and other one is Dr. Deepak Talwar. I request Chetan to introduce Dr. Mateen.
A very good afternoon. I invite Dr. Matinuddin sir for his lecture. He is a senior consultant pulmonologist and head Department of Pulmonology at KIMS, Hyderabad. As we all know, sir is like very much interested in and is more into academics, and we've been seeing his skills since quite some time, and he's published several articles and papers. Sir will be speaking on understanding CPET, the physics, and performing the test.
Good afternoon, everybody. Of Yashoda Hospital for conducting such a nice program on pulmonary functions. I intentionally put the heading as understand CPET. It's not understanding. You have to understand CPET, because in the basics of CPET, I'm not going to tell you many new things. It's all what all of you know. It's the basic physiology. The only thing is we are correlating too many things, so we get confused. But actually speaking, CPET is not something extraordinary. It's all basic. Any doubts can be discussed comfortably. What I would like to say is, because it's a relatively new modality of investigation, I would like to go from basics. Why at all we have to do CPET? What is the main purpose of doing CPET? What actually is CPET? And what are the parameters which are measured in CPET, cardiopulmonary exercise testing, and how the parameters are deduced from measured parameters, and how they are interpreted for the physical condition of the patient. In the next talk, a very good speaker, Dr. Deepak Talwar, will be dealing with interpretation, so I will be skipping that. The whole CPET relies on simultaneously measurements of respiratory system, cardiovascular system, and musculoskeletal system. The thing is, we subject the patient to a known load of work, and while the patient is working, taking up a known load, we measure the oxygen uptake of the patient, the carbon dioxide liberated by the patient, thereby we try to understand the performance of the patient overall, including the cardiovascular system, respiratory system, exchange mechanism, and the performance utilization of oxygen at the tissue level. What we have to understand is, even at baseline, when the person is resting, when your subject is resting also, we need some energy. And energy is produced in the body by burning the fuel. And for burning the fuel, we need oxygen. At levels of various activities, as the load of activity increases, the requirement of oxygen also increases. So at baseline, a 70 kg individual may need about quarter liter of oxygen. Whereas if he starts walking, he may need about 3/4 liters of oxygen. And if he starts running, he may need about 2 liters of oxygen. And if he is doing some strenuous exercise like cycling or heavy exercises, he may need about 4.5 liters of oxygen. So as the activity increases, the oxygen consumption increases. Similarly, the oxygen consumption depends on the body weight also. A 70 kg individual at rest may need around quarter liter of oxygen per minute, whereas a 130 kg individual may need around half a liter of oxygen. So as the weight increases, the oxygen requirement also increases. As the load increases, as the work capacity increases, the oxygen requirement increases. So higher the weight, higher the oxygen requirement. So oxygen at rest is usually VO2, the dot over the V reflects the consumption of oxygen, the volume of oxygen consumed over a particular period of time. So it is given in the units of milliliter per kg body weight per minute. So for a 70 kg, it is about 3.5 ml per kg per minute, and according to the weight you can calculate. The trick here is we make the patient, it's a dynamic test. Throughout yesterday and till today morning, we were discussing most about the static pulmonary function tests. But here, from the last lecture, that was 6-minute walk, we have come on to the dynamic pulmonary function tests. Here, we subject the patient to work. Like in 6 minutes, we make the patient walk for 6 minutes, but here we subject the patient to a known load of work, and work is given in steps or a continuous increase in workload to a maximum capacity of the subject. For this, we measure, can I have a pointer please?
ये वो छोटा रेड वाला आ रहा है.
Okay, fine, fine. So when we are subjecting the patient to work, we have sensors to measure what is the oxygen uptake of the patient. Similarly, we have sensors to measure what is the carbon dioxide output of the patient, and we have treadmill or cycle ergometer to measure the amount of load which we are subjecting the patient to, the amount of work which we are subjecting. So it gives us the idea of whether there is compromise in circulatory system, heart and circulatory system, whether there is compromise in any ventilatory system, or there is any compromise in the gas exchange mechanism of the body, or there is some problem with the metabolic components, that is utilization at the tissue level, mostly muscular level. In this test, there is also a small component of motivation. How good you motivate the patient to perform, that component also gets involved over here. As all of us know, right in the first year of our medicine, in biochemistry, we read glycolysis and Krebs cycle, and we know that there is an aerobic phase of respiration and an anaerobic phase of respiration. If oxygen is comfortably available, then the glucose is metabolized to pyruvic acid and it enters the Krebs cycle utilizing oxygen and gives good amount of energy. So here in the aerobic phase, if oxygen is available, one molecule of carbohydrate, glucose, will utilize about 6 molecules of oxygen and gives about 37 ATPs for ready-made availability of energy. This is important because we are using the anaerobic phase of breathing work to estimate number of parameters. So first understand what is what. For same amount of energy, we may have to, if oxygen is not available, then we may have to use more than 12 molecules of glucose, which will give about 24 molecules of lactate. Using 6 molecules of oxygen, it will liberate only 6 molecules of carbon dioxide. But when there is anaerobic breathing, anaerobic phase, then only for those 37 ATP molecules to be available, you liberate around 16 molecules of carbon dioxide. That is, for the same energy, for aerobic metabolism, we are liberating only 6 molecules of carbon dioxide, and for the same energy in anaerobic phase, we are liberating about 16 molecules, that is more than 2.5 times. So this increase in carbon dioxide level also we will come to know how we deduce the results. So for measuring all these, we require a flow sensor, a carbon dioxide analyzer, an oxygen analyzer, a pulse oximeter to know the saturation, a 12-lead ECG to understand what is the rhythm and when we have to stop or continue to know the heart rate also. Similarly, blood pressure, if blood pressure shoots maximum, then we may have to discontinue the study. And we need either a treadmill or a cycle ergometer to give a measured workload to the subject to perform. This is the lab where complete advanced pulmonary function lab, where a cycle ergometer is there, a treadmill is there, a computerized screen monitor is there, which simultaneously projects number of parameters, because here the oxygen and carbon dioxide sensors are ultra fast sensors which give concentrations breath to breath. That helps in calculating the we can play this? No. हाँ ये वाला वीडियो है नहीं सर छोड़ दो छोड़ दो Yeah, before performing the CPAT, a person has to be subjected to simple spirometry to know the flows and get some expected values. Simple spirometry and clinical examination is a must before performing a CPAT test. Yeah, that video I am not able to play properly. I wanted to show a number of things in that. Here in this figure, we see a cycle ergometer where the person is performing. The mouth is covered by a mask which is airtight but comfortable. It should not press the nose of the patient or make the patient more uncomfortable. It's a snugly fitting mask which is airtight because the amount of air blown out and taken in has to be measured appropriately. So there will be a flow sensor like our simple spirometer. Then there will be a twin tube. These twin tubes, one is for oxygen sensor and one is for carbon dioxide sensor. So breath to breath it measures what amount of carbon dioxide is liberated in each breath, what amount of oxygen goes inside and what amount of oxygen comes outside. Thereby oxygen consumption is also measured. Then we measure blood pressure continuously. There will be 12-lead ECG monitoring to know the heart rate and rhythm of the heart, and we monitor oxygen saturation, and the ergometer gives us the amount of load which we are subjecting the patient to. And these parameters will be projected on a monitor. Usually a big monitor will be there where all parameters will be projected, including saturation, blood pressure, oxygen consumption, everything, and the rhythm of the heart and blood pressure. So the things have become so easy. Earlier the cardiopulmonary exercise testing was very cumbersome, but now the things have become much easier and number of parameters are computed and given on screen very comfortably to us. So what all we get in this? If we remember this, Merecas is one mnemonic where ME for metabolic parameters, we get workload, what is the work rate, oxygen consumption, carbon dioxide production, and respiratory quotient. Earlier we used to call, but now we call it RER, respiratory exchange ratio. Then respiratory parameters, ventilation, minute ventilation, VE is minute ventilation, tidal volume, frequency of breathing, inspiratory capacity, tidal volume, flow volume loop, and oxygen saturation. These are the respiratory parameters which are monitored. And from these two, we deduct oxygen consumption over minute ventilation over oxygen consumption graph. Similarly, end tidal oxygen pressure, end tidal carbon dioxide pressure, minute ventilation over carbon dioxide production. All these we get, these are deduced parameters. These are measured parameters, these are deduced parameters, calculated parameters. Similarly, on cardiovascular side, we continuously monitor ECG, blood pressure, heart rate, oxygen pulse is the deduced parameter again, where oxygen consumption by heart rate is calculated. And we need to monitor symptoms continuously because dyspnea, leg effort, fatigue, chest pain, all these things alarm us whether we have to discontinue the study or we have to closely monitor the patient. Bike or treadmill will give load in watts. I am going to come how we increase the load. ECG, SpO2 give heart rate. Similarly, a triple V sensor will give, that is simple spirometer sensor, tidal volume, breathing frequency, everything. And oxygen analyzer gives us fraction of inspired oxygen and fraction of expired oxygen, and thereby we reduce what is the oxygen consumed in it. Similarly, carbon dioxide analyzer gives fraction of inspired carbon dioxide and fraction of expired carbon dioxide. Thereby we reduce how much carbon dioxide is produced and liberated. If we have luxury, we can record a blood gas to know extra parameters. Lung function testing is done to start with itself. Thereby we extract minute ventilation, maximum oxygen consumption at maximum exercise level, carbon dioxide liberation or carbon dioxide production, respiratory exchange ratio, heart rate reserve. Heart rate reserve and breathing reserve are two important parameters. Minute ventilation is tidal volume into breathing frequency, as simple as that. So, minute ventilation is on these graphs. I will not go into details because when interpretation is done, we will come on to these graphs. Maximum minute ventilation is calculated in two ways, by using the Wassermann equation, which is a bit complicated, or the second method is into FEV1, because we do spirometry to start with itself. So, minute ventilation is given in liters per minute, and maximum minute ventilation is put across maximum predicted. Breathing reserve is labeled as maximum minute ventilation minus ventilation which we record. Maximum minute ventilation is calculated by 40 into FEV1 minus what actually we record, exhaled volume in 1 minute, that is breathing reserve. Or the other way is breathing reserve percentage is maximum voluntary ventilation minus minute ventilation by maximum voluntary ventilation into 100. Don't get confused by these formulae. Once you start practicing, you will start remembering these formulae. So, if the breathing reserve goes less than 15%, then it is normal. If it remains more than that, high breathing reserve, it is pathological. So now VO2 max, maximum oxygen consumption versus peak oxygen consumption. Maximum oxygen consumption is described in normal individuals, healthy individuals, where they can perform and reach the maximum oxygen consumption. And if it is within 20% of the predicted, then it is labeled as normal. But for patients, we calculate peak oxygen consumption, means they cannot go up to the calculated maximum oxygen consumption. So we have to record peak oxygen consumption, which is compromised in cardiovascular patients. When the cardiac performance is inadequate, they cannot reach a maximum oxygen consumption. Average oxygen consumption per minute for an untrained healthy male is about 35 to 40 ml per kg body weight per minute. Whereas for trained, it may go much higher. Similarly, for females, it is about 27 to 31 ml per kg per minute body weight. With training, these parameters can go higher. So how the oxygen consumption is deduced or calculated? That is minute ventilation into fraction of inspired oxygen minus fraction of expired oxygen. Normally, it has to be more than 85% of the predicted. Abnormal, it has to be less than 85% of the predicted value. Means if it is less than 85% of the predicted value, it is assumed to be abnormal. That means patient's performance is inadequate, or the cardiovascular status of the patient is not performing normally. So oxygen consumption is measured in milliliters per minute per increase in load of work, that is measured in watts or kilopascals. So here, as the work increases, the oxygen consumption also increases. But if any of the functions are compromised, then it may slant down. We will discuss in detail when we are going on the graphs. Similarly, carbon dioxide production. I was discussing about the glycolysis and Krebs cycle, if oxygen is available, if oxygen is not available. If in anaerobic respiration, the carbon dioxide production is less. In aerobic respiration, for the same amount of energy, the carbon dioxide production is much more. So here, a graph is depicting volume of oxygen on y-axis and volume of carbon dioxide produced on y-axis with time and load. So up to a particular exercise, the CO2 production will have a slightly slanting uphill, but after that suddenly it goes up. That indicates that the anaerobic metabolism has come into play because the carbon dioxide production increases. So this is helpful in determining the ventilatory threshold. Ventilatory threshold, earlier they used to say abrupt increase in carbon dioxide that depicts anaerobic metabolism, but now it has become more sophisticated. They have ventilatory threshold 1, ventilatory threshold 2, ventilatory threshold 3 has come because of increased carbon dioxide, increased lactic acid and all. So carbon dioxide production in itself is not used to indicate a limitation. The value is used to calculate other parameters such as respiratory exchange ratio and minute ventilation over carbon dioxide production. Respiratory exchange ratio, normally we used to call it respiratory quotient, that is carbon dioxide produced by oxygen consumed. nowadays the respiratory quotient term is not used and it is used as respiratory exchange ratio. Normally it is 0.85 but range from 0.78 to 0.9. But when the patient is performing work, then the ratio may increase to 1 or even above 1. 1.2 to 1.3 at maximum exercise level. That is what depicted here in the graph. I was talking about CO2 and O2. The blue line depicts CO2 and the red line depicts O2 consumption. The blue line depicts CO2 production. So O2 consumption and CO2 production go hand in hand. The two lines are together up to here. Then it is flattening. Again it is directly shooting up. So this point at one point of time was thought and starting of anaerobic metabolism. At certain point of time it crosses the oxygen line and goes much up. So here nowadays because of lactic acid accumulation also the pH goes up, CO2 production goes up. This is called VT1, VT2 and VT3. We at time of interpretation we will go into that. Heart rate reserve. Heart rate reserve is also an important parameter. What is the predicted heart rate, maximum predicted heart rate minus measured heart rate? That is called the heart rate reserve. At rest, the maximum heart rate is 150 to 200. Stroke volume and cardiac output, it multiplies as the work increases. So when the person is performing the maximum, his or her heart rate reserve has to be less than 15. If it does not reach less than 15, then if it is more than 15 per minute, then there has to be some cardiovascular problem or person has to be on some drugs which control the heart rate like beta blockers. Yes. Now for most of the parameters at the peak exercise level, the exercise has to be performed for a minimum of 8 to 12 minutes. I am going to come on what is protocol, ramp protocol and slope protocol. Exercise has to be optimally performed for 8 to 12 minutes. It cannot be performed for too long or too short. Then workload predicted has to be more than 80% of the predicted value. Respiratory exchange ratio has to be more than 1.15 because as the work increases, the respiratory exchange ratio also increases. Blood pressure has to be less than 20. If it is crossing 220 systolic, then we may have to discontinue the study. Patient can't tolerate that. Similarly, heart rate has to be more than 90% of the predicted. If it is not reaching more than 90% of the predicted, just now I told either it has to be because of the cardiac issues, rhythm issues or some drugs. Performance of the heart is suboptimal. Similarly, heart rate recovery will also be around more than 12. Peak oxygen consumption predicted has to be more than 84% of the predicted. If it is less than that, then it appears to be pathologic. I am skipping anaerobic threshold. oxygen pulse. Oxygen pulse is oxygen carried per heartbeat. Oxygen pulse has to be more than 80%. If it is not that much, then there is some problem with the oxygen carrying capacity of the blood or oxygenation. So, oxygen consumption by work is shown in ml per minute per watt. It has to be 9 to 11 ml, that is normal. Breathing frequency has to be less than 60. Breathing reserve has to be more than 20 to 40. End tidal carbon dioxide at baseline has to be more than 33.
Mateen,
yes.
How many slides are there? Just you have to close the session.
Okay. So basically, oxygen consumption depends upon the heart rate into stroke volume into oxygen content of the blood or oxygen delivered to the blood. Oxygen delivered to the blood is arterial oxygen content minus venous oxygen content. So heart rate is affected if there is some sinus node problem or some drugs are used. Stroke volume is affected in cardiomyopathies because the contractility is affected, or if end diastolic volume or end systolic volume is affected. Similarly, oxygen content of the blood can be affected if PaO2 is less, mostly in pulmonary issues, or non-availability of oxygen, if the hemoglobin is low like in anemias, or the pulmonary capacity is problem with the ventilation. Similarly, oxygen content of the venous blood depicts probably metabolically it is not completely utilized. So, the problem with the skeletal muscles or utilization of oxygen at the tissue level, and the problem can be with the blood flow to the tissues also. So, theoretical limitations of oxygen consumption can be because of the respiratory system, because of the skeletal system, musculoskeletal system, because of the cardiovascular system also, and nervous system. Yeah, when we are deciding the protocol, means we are subjecting the patient to the increasing workload. Increasing workload can be a step increase after every minute or every 2 minutes, or it can be a constant increase every 10 seconds. So this is called a step protocol, where at 1 to 2 minutes decided by us, a increase in workload is given, or constant increase. This is called ramp protocol. This is called, both protocols are valid, but ramp protocol gives the ventilatory thresholds more precisely. That is why some of the people prefer ramp protocols, but equally good is step protocol, because at every 1 to 2 minutes we keep increasing the workload. So how we need to individualize the protocol? A good performing athlete, the protocol has to be different, the workload has to be much higher, whereas if you are doing in patients for clinical purposes, then the workload has to be much less. So determination, individualizing the protocol depends upon the body weight of the patient, predicted peak work rate of the patient. If you are using treadmill, we need to use the initial and peak treadmill velocities, and also the increase in height of the treadmill also, thereby increasing the workload. These are all computerized and calculated. As I said, before the start of the test, it is recommended to perform a standard lung function test before the exercise, so that we get FEV1 to calculate maximum ventilation. Predicted is maximum oxygen FEV1 into 40, maximum ventilation, and thereby work of breathing. I have few more slides. Sorry?
In the interest of time, if you go to the concluding style, I think.
Okay.
Yeah.
Here I wanted to show the basic thing is we project oxygen consumption over workload. On the y-axis, oxygen consumption is there. On the x-axis, load in watts is projected. So the basic physiology is when we are performing a cardiopulmonary exercise test, we first make the patient rest, and at rest, for an average 70 kg individual, the consumption of oxygen, as I said, will be around quarter liter, 245 ml of oxygen. That is about 3.5 ml of oxygen per kg body weight per minute. Then we ask the patient to do light cycling or unloaded treadmill, just keep walking at comfortable space. At that point of time, the expected consumption of oxygen will be about 7.5 ml per kg body weight per minute. So it comes for 70 kg man, it comes to around more than half a liter of oxygen per minute. For the same individual, as we start increasing the workload, the consumption of oxygen increases by about 10 ml of oxygen per minute per watt increase in workload. So up to 100 watts, when 100 watt load is given, that 70 kg man may consume about 1.5 liters of oxygen per minute. Then again, as workload is increased up to 200, same, this is for a normal individual, neither a trained athlete nor a patient. To understand the physiology, we are depicting this. So for a normal man who is exercising up to 200 watts, then the oxygen consumption will be around 2.5 liters. Here it is shown 2.5 liters of oxygen in a minute. And after performance, patient should not abruptly stop exercising. So patient has to continue pedaling if treadmill is, cycle ergometer is used.
Mateen, we have a workshop, na? CPET workshop. You can discuss these things because Talwar has to leave. Talwar has to attend a meeting, then he has to leave.
Okay.
The next speaker. You have to understand.
After
you can
the
discuss
patient-
these during the workshop. Huh? Sorry for stopping you. I have no other option except this.
Indications for CPET is assessing exercise tolerance and what are the limiting factors, potential limiting factors, then assessing impairment in chronic lung disease. If we corroborate things properly, we can decide the type of lung disease, we can decide what is the cardiovascular limitation, what are the problems with the vascular system, what are the problems with the musculoskeletal system. There are certain indications for termination, contraindications as well as termination of the exercise. If patient develops a chest pain, suggestive ischemia, ischemic changes in the ECG, any heart block, any ectopics frequently coming to the patient, hypertension, blood pressure going beyond 250 millimeter of mercury, systolic or more than 120 millimeter diastolic, severe desaturation. If the saturation is going less than 80% also, we may have to discontinue the study. Sudden pallor that may develop because of the hypotension. Loss of coordination, patient mental status may not be good, patient may look confused and not follow your commands adequately, then also you have to discontinue the study. And any signs of respiratory failure. Otherwise, if we are inadvertent and continue, the patients may collapse, because there are studies where in CPET about 1% of catastrophes have occurred. So we have to be very cautious when we are performing the test. So what are the goals of exercise testing? Accurately evaluate exercise tolerance. I think I have to finish over here, and Dr. Talwar will be dealing with interpretation of these values.
Yeah, Thank you, Dr. Mateen. Uh, After knowing what is CPET, what is the basics about the basics of CPET, and how to do the testing and various protocol, we have to know how to interpret the test. To discuss this, we have with us Dr. Deepak Talwar. I think Deepak Talwar was already introduced to this audience. You know what? He was missing for 1 hour. Where he has gone, you know? He has delivered one more lecture online. So I think Dr. Deepak Talwar is the organizing secretary of Indian Chess Society. He is the live wife for all the academic programs. I used to tell him he spend more time on air rather than the land. I am suggesting to buy a chartered flight to attend all the academic programs. I think this is the 9th time in the last 2 months he is in Hyderabad, and we are also seeing a flat for him in Hyderabad. So without wasting time, I request Dr. Deepak to go ahead with this presentation of how to interpret CPET.
Thank you from the bottom of my heart, Dr. Kandi, for using such a wonderful introduction for me.
Tell them that they're giving the paper.
So you are all getting these cases which I am going to discuss. So the theory part, which was the most difficult part, has been very kindly and very nicely dealt by Dr. Mateen. So thank you, Dr. Mateen, for doing the hard job for me. Now my job is very simple. Now the moment you see the CPAT report in your hand, the first thing which comes to your mind is, this is not for me, right? So obviously I can understand. Okay, so please try to share it, because we have 50 copies and there are 7 cases and I have to next half an hour complete these 7 cases. My job is to make it interpretation like a ziffy. It should just come to you and you should realize that what is to be done and how you can do it effectively. Now, before we start this, in the meantime, you're getting these papers. Remember, this is this gentleman who's doing the bicycling. He's doing a CPAT test. What is being tested here? What is we are testing here? Now basically he has to cycle, na? The legs have to move, the muscle in the leg, right? The muscle is asking for what? It is asking for oxygen, energy. Who's providing it? The lungs. Who is carrying it? Heart. Who is carrying it into the muscle? The circulation. And what are the muscles doing? There is a metabolism there, which is ATP generation, which is happening. So mitochondria. So you can see that it starts from these 4 systems which are required to work in cohesion, so that this gentleman who's put on to CPAT is able to do the 10-minute of exercise which is required. Dr. Mateen has told you this is a test which is only limited by when the patient says that I cannot do any more. So actually you made the patient suffer. That's what the bottom line is it. Exhaustion. Exhaustion means I can't do any more. So that time you determine what is limiting. And you have to ask him, what's the problem? He'll say that I can't breathe. Okay. He can say my legs are paining too much. 2, 3, chest pain I have developed. Right? So all these have different meaning. Anybody who stops because he can't breathe anymore, so it gives an idea to me that respiratory system has been stretched to maximum and he can't breathe anymore. If somebody develops a chest pain, I know that I have to look at the ECG, there seems to be a cardiac limitation. Leg pain, normal person, not like me, but maybe like Dr. Kandi or maybe Dr. Nagarjuna is the right person. If he does it, at the end of 10 minutes, he stops it and I ask him, what's the problem? He'll say leg pain. That's a normal person. A normal person will stop the exercise only because of the leg pain, because the muscle which is doing this exercise is no longer able to generate enough ATPs to carry on the activity. That's how a normal person is supposed to terminate the exercise. But anything which does not take oxygen down into the muscles is also going to terminate with the leg pain. So we have to consider that in all perspective of whatever is happening here. So if all of you have got it, Okay, so I think the cartoon is trying to become better and better by telling you my heart is beating very fast, I am breathing very fast, and my legs are working but they are hurting, and the circulation was also telling us that there is some problem coming up. Okay, this complex mechanism, by just 3 measurements, only 3 measurements, how much of oxygen is going in, how much of carbon dioxide is going out, and what is the total amount of air which has gone in with each and every breath, breath by breath. Only 3 sensors in it, and all 3 sensors are online. Breath by breath analysis. It's that simple. It looks like very, very simple thing, because oxygen and carbon dioxide are the 2 things which are actually doing the metabolism, and the amount of air you need to actually substantiate as to how much is the curve with the VO2, VCO2. So as I told you, at the end of this exercise test, what you need to document is what was the reason to terminate this test. If patient completed it, well and good. If patient did not complete it, at 6 minutes he said, I can't do any more, then you need to document it, because you need to find out this Wassermann wheels, that where the wheel has got stuck. Where was the problem? Is it in the muscle? Is it in the heart? Or is it in the lungs? Or is it in the circulations, pulmonary and systemic? And you can see the number of causes which are all written here. I'm not going to go to that, but I'm going to discuss that with you once we go to the cases. Now, I am not again going into all the physiology which Dr. Mateen has taught you, but all the physiology has been brought into this 9 graphs. They look horrible. I'm pretty sure the first time when we saw it, even we got scared that what is this kind of situation we have got into, where we have to read this 9 kind of a graphs. Although Dr. Mateen did tell you some of them, but what I will do is dissect these 9 graphs and then go to the cases, right? First graph is very simple graph. Okay, so let's see when CPAT done. I don't want to tell you, any patient who has unexplained dyspnea will be requiring a CPAT to find out why is his dyspneic. Any patient who requires a preoperative evaluation for pneumonectomy, lobectomies, they need to undergo that CPAT to qualify to that criteria that the post-operative mortality and morbidity is going to be low. There are always other things which you can do it about, like monitoring after rehabilitation and various other things which you do in your routine practice. But by and large, in clinical practice, when lung functions, which are lung volumes, the spirometry, the lung volumes, diffusion study, IOS, everything has come back to normal, and patient says, I am breathless. What are you next going to say? Go and meet a psychiatrist. Then that must be the only reason. We don't do that. We put them onto this test. We try to see that is it really anxiety or is it something else. Peripheral deconditioning is the most important thing, and that's happened in COVID. They are breathless, their lungs are good. They are breathless because their muscles are not able to do the exercise and produces the breathlessness part there. So CPAT is used that. So just to tell you that why these 9 graphs are like this, these are called as classical Wassermann graphs. And they have been given in this kind of a fashion where you are identifying that what is the cause of limitation of exercise. That's the way, that's the reason why you have done the CPAT for the patient. He says that I am not able to do my activities, I am breathless, I do not know what to do, I'm too lethargic, I cannot do. So you just tell him, okay, do it, I will find out what's the problem going on. And this is being analyzed in this way. I will show you a little later how it is done. But right now, I do not know what happened, but the graph got totally changed. All of the graphs have actually become inclined and transfer from my laptop to this. I do not know how it happened. So in fact, it's just showing that you keep on doing the exercise. So wattage is increasing accordingly to 10 minutes. Dr. Mateen told you that we do it like 10 watts per minute or 20 watts per minute, but remember we have to do 10 minutes. So if an athlete is put up for the exercise test, which like he's expected to do 200 watts, we have to go 20 watts per minute increment. But if there is a patient who can do just 50 watts, then we are going to put 5 watts per minute for him. So that at least 10 minutes of exercise time is to be obtained in individual patient. And this has been smoothened so that you can see the straight graph. Next line, what you're seeing there is actually the first graph, which is here, the ventilation. So ventilation keeps on increasing as the exercise increases until it reaches the peak. Once you stop it, it comes back to normal. So VE is the important aspect in the first graph which you are seeing. So this is simple to understand. You are doing more exercise, so you are breathing more. So your ventilation is increasing. The amount of air you are taking in is increasing. What? Yeah, so I think I'll skip these graphs. I will just show them these graphs one by one. So this was just blown out to show you how they look like in this particular picture. These are the graphs which has been taken up from the different machine. We have two CPAT machines. This is the Genshom machine, and this is the Cosmed machine. There are two different machines. But all graph configurations as well as their other values would remain the same. So even this, the adjustment, you can change actually. I can change 6 number to 7 and bring 7 to 6, but that doesn't serve the purpose. So that is why they are all standardized. The second one, which you can see that, VO2 over heart rate. And Dr. Mateen has told you, what is VO2 over heart rate? Tell me. What is VO2 over heart rate? He has used that cardiac output formula. This is stroke volume. This is a non-invasive method of determining cardiac output. Stroke volume is the one because you already have a heart rate, and stroke volume into heart rate is equal to cardiac output. So this is a non-invasive method, and what is happening is, as you are increasing your exercise, then this stroke volume is increasing, and it is clearly showing with the heart rate. Just focus on the B, graph number B. I can have the arrow. Arrow is seen? Yeah, just look at it here. Oh, this... It's moving faster than me actually. So you can see that heart rate response is much more than the stroke volume. We all know the stroke volume can increase maximally how much? 150%, 180%, and athletes up to 200%, normally about 120 to 140%. But heart rate is going to double. From 70 to 140, 140 to 210, you can go a huge response. So you can see that as the person is exercising, the heart rate responds much more, but the stroke volume is also increasing, but not to that extent, but trying to parallel the change which happens in the... This is primarily the graph which tells us there is a cardiac limitation. Heart is in trouble or not. So when we start looking at that, what is the exercise limiting cause? So if the heart is the cause, we start looking at this stroke volume heart rate curves. This is the second number graph, B number graph, which tells us things are not really good as far as the heart is concerned. Third graph, which is coming like VO2, VCO2 with a work which is going on. You can see that as you do more and more work, you need more oxygen, you actually throw out more carbon dioxide. Simple procedure. So you can see that the graphs are actually going incline up parallel to the increase in work. So more exercise, more VO2, more CO2, VCO2, all are going there. But very important thing is you can see that the blue curves, the blue lines have crossed the right one, the blue one, roughly at about the last 20% of the exercise. What has happened here? The VCO2 curve crossed the VO2 curve. So that means CO2 production is more than the VO2 which is going inside. When it happens, anaerobic metabolism. Excellent. You people know everything actually. Why? Then it is not difficult. You have understood. So that is the AT level. And you can roughly see that instead of this 12 minutes, this AT has occurred at 9 minutes. So at 9 minutes, the patient would have done definitely more than 60 to 70% of his exercise to get an AT. And if it is less than 40%, then only it is indicative of early AT. Early AT is an indicator that the muscles are changing from aerobic metabolism to anaerobic metabolism because of lack of oxygen. Now, lack of oxygen could be because the muscle is bad, or the heart is not supplying, or the ventilatory system is not supplying. So it is just trying to tell us that anaerobic metabolism is occurring early, and that is an indication that perhaps we have to look for it, that this patient is not conditioned even. He needs to improve. So in athletes, what we do is we improve this AT level to almost about 85% actually. So they go in that training where their AT levels are increased. So that is the graph which is very important to tell us the response of VO2, VCO2 to identify where the AT has occurred. And it is clearly telling you where the change has occurred. Important thing is the blue and the red dots, at one point of time, they are just over each other, right? Finally, before crossing. So that is why AT is never a single value. It is a zone where it is happening. So it is like it may happen about 30 seconds, 40 seconds when consistently O2, CO2 are equal and then finally the CO2 goes up. That tells you, yes, this is accurately AT identified, because in a lot of CPAT tests, you are not able to find out exactly where the AT is. That's why there are other methods used for it. Ventilation, obviously you know that ventilation is increasing. You need more ventilation when you do exercises. And then this is the graph which is trying to show you basically the response to the heart rate response to the VO2, which is again equivalent. It is also showing an AT value, and it is also showing how the heart is behaving. So if there is something wrong, the patient who's like very, very anxious, it goes into total haywire. From 6, so it starts with 80, 90, goes to 110 and shoots to 200. So that is showing that either there is a cardiac issue or there is an anxiety issue with this patient. It should not have happened. So this kind of a graph, which is like a normal graph going up, showing that with each increase in activity and exercise, the heart rate increases, which normally should happen. If suddenly out of blue, something happens where the heart rate goes total bizarre, it tells you that either the patient has anxiety or a cardiac issues were there. Then finally, this F graph, which is again combined with the I graph, these are the gas exchange graphs, VO2, V over VO2, VO2 over VCO2, and PET O2 and PET CO2. So gas exchange is primarily being looked after at these two graphs. These we will discuss when you see these cases. And then finally, these two lower ones which are there, they are basically looking at the first one, whether the patient is increasing tidal volume more or increasing the respiratory more. If you increase your respiration, you have to increase your minute ventilation. You have to increase both. You have to increase tidal volume, you have to increase your respiratory rate. But individually, depending upon a patient to patient, you will decide that what kind of a lung disease will allow more respiratory rate to increase, and which kind of lung disease or other diseases will like to increase more tidal volumes. So that kind of a response is being seen here, which can tell what Dr. Mateen said, that whether the patient has ILD or a patient has a COPD, because whether you increase your tidal volume or your respiratory rate depends upon the underlying lung disease. And RER is the respiratory exchange ratio. This is again a very good thing first thing to be seen, whether the patient has actually done the test well or not. So considering all this, I've skipped all these slides and saved a lot of time. So I bring you to this. This is a composite picture which is trying to tell us that if you do blood lactate levels, that tells us when the blood lactate starts rising above 2, which is the 80 threshold. You can't put an arterial cannula to do an arterial lactate in these patients. The entire, the benefit of a cardiopulmonary exercise testing being non-invasive will become invasive. So you don't have to do that. So these surrogate markers of increase in lactate in those graphs, you can clearly see there is an upward trend suddenly on ventilation, VCO2 graphs, VO2 graphs, and these are the 3 graphs which are the primary ones to determine the AT, or at the point where the lactate accumulation starts or where the lactic acidosis is happening, which is called as anaerobic threshold. Normally 35 to 80%, and it's a zone as I told you. So in interpretation, the first point is to see whether the VO2 is achieved or not, and all these things I don't think so I will do it, but we'll do it as the case comes. And this is again, the graph has come wrongly, but it is telling you the green color is indicative of that it is what kind of an abnormality it is coming. So you can see that the gas exchange and abnormalities are coming in the green in color, which I think the colors have totally changed here. The red ones are the cardiac ones, and the black ones are the pulmonary ones. So this is the algorithm to read. So I'll leave this algorithm here and pick up the first case, right? The first case is Mr. Malik, right? Please take out this case, which is Mr. Malik. Yeah, this is it. So although the report comes out like about 18 to 20 pages, nobody reads that actually. All you need to read is this 3 pages, 1, 2, and that 3. 3 is the saturation one. If you add one of the graph extra on the saturation, you don't need that also. It will be completing the whole thing here only. So the first thing to be seen when you do this is that whether the test, Mr. Malik, do you have that Mr. Malik with you? Mahendra Singh Malik, you all have that? Okay. So first question to be answered is this CPAT worth interpretation or not? So that's the standard question, right? From yesterday you are listening to that. Is this spirometry worth or not? Is iOS worth reporting or not? Is the lung volumes good enough? Is the diffusion capacity? So all those standards. So what's the standard for CPAT? Again, I told you, RER. So you can see RER maximum which the patient has received is 1.12, and he started with somewhere around 0.8. So that we know that at the resting levels, the respiratory exchange ratio, because of the oxygen versus carbon dioxide produced by glucose metabolism, is about 0.85. So you are supposed to start the exercise at that level. So that's why you are not taking your lunch when you start, and we are also actually hungry. We didn't have our lunch. So right time to do the exercise test for us even. So you can see that 1.12. Ideal would be like 1.15, but any value which is above 1.1 is considered as the patient has stressed enough to get that good test done. So first test passed, that this test is interpretable, right? Now second, the most important question, that is this patient, you can see that, yes, achieved peak PO2 or not. So let's see whether he has achieved peak PO2. So what is the peak VO2? The first parameter on the metabolic response, VO2. There are number of things written here. Predicted, rest, warm up, 80%, predicted, RCP, max load, percent recovery, so many things. Which one to read? Which one to read? Right, maximum load. At maximum load, what was VO2 max? Now, what is the difference between VO2 max and VO2 peak? VO2 max is a predicted value. If you reach that, you have reached VO2 max. But if you are not, then whatever is your VO2 maximum is called VO2 peak. So you desire to reach VO2 max, but you may end up with something which is lesser than that, but you have to call it, and you call it VO2 peak. So in this patient, you can see that he was predicted to get a VO2 of liters per minute 3.05, and he achieved 2.61. So he did not receive VO2 max, but he did receive a higher value, which is called VO2 peak, which is 2.61. Is that right? Is that clear? Is that clear with everybody? And you see what is next written to it? 86% of predicted. Right? Is that right? Okay, so come back to this. So any value above 85 is considered as normal. So the first interpretation of this test is that patient is able to perform the test with adequate standards and has been able to complete to achieve the VO2 max to the tune of where it is acceptable normal. Now, if this patient says that I am breathless and dyspneic, then I will have to consider that what are the three causes when VO2 max or peak, whatever you want to say, is normal and the patient is still complaining of breathlessness. So three causes: anxiety, 2, obesity, and 3, very, very mild disease which is not picked up, which happens in mostly people who are like in good physique. Patients don't have that kind of a physique. So you will be able to definitely not reach 86% in an individual who is complaining breathlessness on exertion and has a mild disease like mild COPD or a mild ILD. So once it is normal, you have left out only about at these causes, right? So go back. Okay, we go back. So you have all seen that BMI is 27.1, not an obese individual at all. Now anxiety versus what you call mild disease. Now anxiety, as I told you, we don't send them to straight away to psychiatrist. We look at this graph. What is this? Ventilatory equivalents of oxygen and carbon dioxide which change breath by breath. So what happens in anxiety? There are deep breaths, there are shallow breaths, and this is what is characterized by anxiety on a exercise testing. So look at that graph on which you are seeing that red dot. That is the ventilatory equivalents of oxygen and carbon dioxide. And you can see, despite buffering, which is done by the machine, there are still spikes up and down, up and down. What is it showing is breath by breath, oxygen and carbon dioxide is fluctuating, which means patient's breathing is changing from deep to sigh to very short breaths over a period of when the patient is exercising. How can it happen? Do yourself a cycling and see that. Can you do that? It cannot happen. It only happens in anxiety. And that's a classical pattern which you get in a patient who develops anxiety on an exercise and causes dyspnea at that point of time. So this is the classical pattern which is called as dysfunctional breathing. We don't call it anything like anxiety or hyperventilation syndromes. We call them dysfunctional breathing. So this is the pattern which explains why this patient has dyspnea, right? Good. Now, this is a case which is not with you. So this is again a post-COVID 28 years. Look at the lung functions, everything normal from top to bottom. Lung volumes, diffusion, everything normal. Huh? Everything is normal. Now, this patient is complaining of breathlessness. How do we go about them? We invariably think that you are very anxious. That's the most important thing. Put them onto CPAT. What has happened? Look at the first parameter. Right? What is the first parameter? VO2 is? How much is VO2 max? 80%. So it's less than 85%. So although there is a very good response, but patient did not achieve the maximum which was required. So peak VO2 or max VO2 is reduced. So exercise capacity is reduced. That's the first thing. Of course, you will look at RER, which I didn't tell you here, but 1.15 has been achieved again in this patient. So patient has put in his efforts. So test has been done up to the mark. Only thing is patient could not get VO2 max. So there is decrease in exercise capacity. The moment you come to this, the next question is it because of lungs? Is it because of heart? Is it because of his muscle? Or is it related to just a poor effort of the patient? So look at these parameters now. What are we getting here? The next parameter is to look at it, most probably in COVID is my lungs bad, right? Is my lungs bad? So this parameter to look at whether your lungs are good or not and could have carried on the exercise more, 5% which was required, is to look at what is called as breathing reserve. And he told you that you need to do MVV calculation prior to starting the test by you having an FEV1 and multiply it by 35 or 40, whatever number you want to use there. The idea is to calculate what is the MVV and what is the maximum achievable by the patient and the reserve left. There has to be a reserve left. So when you stop exercise, you will never stop exercise because there was no breathing reserve left. In a normal person, it will not happen. There has to be minimum of 15% and maximum of 30% in a normal person to have a breathing reserve. So when you terminate the exercise, lungs would have not stopped you to continue. They would have allowed you to do. So what you do and why you could terminate at that point of time, even if you are normal, is because of your leg fatigue, not because the lungs wouldn't have carried on further, right? So you look for a breathing reserve. So look at the breathing reserve. How much it is there? You can see 41%. 31 to 41%. So which it means is that even at maximum exercise, patient had a respiratory reserve of nearly 40% with him. So if we put that it couldn't go below 15, so what it means is that nearly 25% of breathing reserve was there and patient should have done more. Why patient didn't do it? So that means lungs are not at fault in this patient at all. Nothing wrong with the lungs, okay? So if lungs are not wrong, the next thing is to look at the cardiac parameters. Is it heart weak? Because everybody then after the COVID, they think now if the lungs are good, doc, then must be my heart. Now what do you look for heart? Heart, you look for two things, heart rate and stroke volume. So that is these cardiovascular response. Heart rate has been achieved to how much? 93? I can't see that. What is it? Huh? Do I have a collar mic? No? Okay. Okay. 93%. So heart rate is quite good, actually. It did, oh yeah, that will do. Yeah, that will do. So it has reached 93%. So he has been able to achieve a good heart rate response. So chronotropic response from the heart is good. Then comes the inotropic. Inotropic is on contractility and will be determined by stroke volume. Is that clear? Is that clear or not? The cardiovascular response is to give more blood to the muscle. And for that supply, that needs to increase its heart rate as well as the stroke volume. So heart rate increased quite well. Now looking at the stroke volume. And I told you stroke volume is oxygen pulse, O2 pulse. That's the non-invasive surrogate marker of this stroke volume. And how much did it increase? 88%. So that means even his stroke volume also increased very well. So even the heart is not bad. So what is happening here? So we go on to the gas exchange. So is the gas exchange bad? So we look at the gas exchange parameters, and gas exchange parameters all dip and then rise, which is classical pattern which you are seeing here, and plus you will look at the saturation also, that everything is again normal. So what is happening? Is this patient having a poor muscle which is causing his breathlessness? So for that we need to identify the AT. So look at your VO2 and you can look at the AT and look at the AT at that 73%. So he has achieved his anaerobic threshold at 73%, which is a very high one. But anyways, you need to always confirm, because these are the mathematical values which are done by the computer. You need to check it whether it is correct or not. But anyways, 73 will never become 35 or 40. It may become around 50, but never so low it is becoming. So there is actually, if you look at it, there is nothing which is coming up to tell us that early anaerobic threshold has come. But then, now you look at the heart rate reserve ratios. Very high ratios are coming there. So you can see that, which is primarily the effect of poor conditioning of the patient. So he is dyspneic just because of poor conditioning. All he needs is a rehabilitation, nothing else, and a reassurance. Rest, everything is normal with this patient. So we move on to the next case, which is, let me see, which is this one. Okay. Vanshika. Yeah, I think this is Vanshika Agarwal. And just a small request for the postgraduates that if you use these cases for teaching in your purposes, please black out the name of the patient. Don't use the name of the patient at all. I was in a hurry, I couldn't do it, but please don't let these papers float around with the name of the patient. Please, just the name part. Okay, so now this is a case. So you can see that. So first question, has the patient done the test well? Is it interpretable? Yeah, very good. 1.08 is at the RCP, but maximum load 1.38, so more than 1.15. Actually, patient has put in our best efforts to do the test, no doubt about it. Is it normal? Is it normal? Yes? So next thing is did the patient achieve VO2 peak? No. Anybody says yes? Raise your hand. If you say, I will show you, because we need to understand where we are looking at, because these, I'm sure that you are all absolutely actually confused with so many things which are being shown here. But VO2 is the first parameter which you are looking at, and you can look at that. In fact, I will say that even the first one, the load, predicted was we wanted to give her 123. So 123 would roughly mean 12 watts per minute. So this patient would have required to be put on to bicycle for 10 minutes with 12 watts per minute. That can always be changed individually patient to patient. And this patient achieved the maximum load of 125. Actually almost reached 100% predicted. So all the exercise has been done well by the patient, right? Okay. So now we look at the VO2 peak, which is coming to maximum at max load is 1.12, which is equivalent to 63% right on the top. Can you read that? Clear? Those who are sitting right at the back, are you able to see anything? Or you don't like this? If you don't like this, you can easily walk out. There's no problem actually. I'm not there to teach everybody who's not interested. I'm only here to teach people who are interested in knowing it. If you're not interested, it's okay. Chill, sleep. Get up only when the lunch is ready, okay? No problems. Because if I were you, I would have been sitting right in the front to learn that what is this, because this is very tough, but actually it is not tough. It is very, very simple. Only thing is you need to understand the algorithm. And if you know the algorithm and your basics, then there's nothing in interpreting a CPAT which is going to make a mistake in that. So peak VO2 is 63%. So despite doing all the exercise and everything, the patient did not achieve the VO2 max. So the exercise capacity is limited, no doubt about it. Now we have to look at it, is it the lungs or is it the heart? And we are the pulmonologists. So always we will look for first what? Lungs at fault or not. And as I told you, the best thing to lungs at fault is to look at the breathing reserve, BR. So BR is coming as what? Anybody can tell me on this? I'm not going to give any hint. What is the value of BR in your patient? The patient who has achieved BR, breathing reserve, was how much in this patient when she terminated the exercise? Minus 27. Excellent. This can never ever happen in a normal person. It only happens in patients who have respiratory disease, because their breathing reserve will come to zero actually, because they will be left with nothing, because FEV1 is low. If FEV1 was normal, then the MVV would have been very high, then the breathing reserve would have been totally different. So that means that MVV for that has come down so significantly that patient has gone on to encroach upon the breathing reserve, and not only to that, it has gone even beyond that. So that means the MVV was very low for this patient, and that means patient had very low FEV1. Could be obstructive, could be restrictive. So now we know that this patient has got a ventilatory limitation. But who knows, there may be a cardiac limitation also. So that for that you come back to the heart rate response, which is 132%, and come to the stroke volume, which is coming to 69%. Now you can say that 69% is not very good. We want to have 80, 85 for the patient. But the question is here that even if this patient would have continued, it would have gone on to more than that, but the lungs had already stopped it. Patient couldn't have done. This patient would have typically said at the end of it that I can't breathe anymore. So there is nothing more which I can do here. And you can look at the saturations. All gone, the lowest is I think 94 and the maximum is 97. So just about a 3% fall. We generally consider 4% in CPAT as a significant one. So some fall, again indicating some gas exchange abnormality also happening along with the ventilatory limitation. So patient would have certain things which would be there, which we need to consider there. But another way of looking at is this graph actually. You can see that breathing reserve is actually gone to zero. In fact, it has gone negative. The graph can't go below that, so it has just stopped there. So I'm sure the machine got haywire totally. What has happened to this patient? How could he reach that? Okay, so oxygen pulse would have definitely gone more in this patient. And also, when you look at that graph, number 2, that is the stroke volume graph, which is trying to show you that it is nicely was going up. But anyways, this was the maximum this patient could go because of the ventilatory limitation was there. And then you look at the other things which are like 80. So you go back to 80 to look at it, what is VO2 at 80? And it is coming at 47% again. So 47% means that a good amount it. So you can see that graph number 3, that is the 80 graph. The red curve was going along with the blue curve, and suddenly, nearly at the end of the exercise, just before the exercise ends, it crossed over immediately. The CO2 started rising very, very much. And if you look at the 2 graphs, they are also showing you the CO2 graph is very, very steep in comparison to oxygen. So there is a gas exchange abnormality happening. So completely a ventilatory defect with a gas exchange abnormality, which is causing a breathlessness in this kind of a patient, right? We move on to the next case. And please stop me wherever the time is over. Please stop me, because these are all cases we can stop at any number. There's no problem. So this is the next one. Next one has come? No.
Talwar sir, you can have this case. After that, we'll close.
Okay, so this is the last case I will take. Okay, fine. So then in that case, let me see which one I want to discuss. Huh? Somebody wants to do Anirudh? So, or you want a cardiac limitation? I think we can go ahead with a cardiac limitation. Let me see, which is that case. Okay. Afruza. Can you take Afruza? Yeah. Is this the one? Is this the one? Is this the one? Now, I think we can clearly see that she achieved 47% of the load of the exercise only. Although RER has been 1.18 in this patient, but she could only do 50% of the exercise. And we also see that VO2 is coming to 35%. Severe exercise capacity limitation in this patient is there. And then the important thing is that quickly going through the breathing reserve 24.7 to 19.7. So predicted is somewhere around like 19.7% would be considered as a more than 15%. So still some ventilatory reserve was left. When we come down to something like oxygen pulse, just 40%. So you can see that there is a cardiac limitation because the stroke volume did not increase, the cardiac output did not increase. You can see the chart which shows that the saturation went down to almost about 85%. So she has desaturated. There was a significant respiratory reserve, so there is not a ventilatory limitation. The patient has an exercise limitation due to cardiac limitation, and the cause of cardiac limitation, now you have to see what is it, the cardiac limitation. So if you look at the gas exchange abnormality coming up in a cardiac limitation, then there's only one disease which comes at, that is pulmonary arterial hypertension, PH. And this is one of the standard indication to perform CPAT when you suspect pulmonary arterial hypertension. So if you have a COPD with pulmonary hypertension, ILD with pulmonary hypertension, and you want to find out how bad is the pulmonary hypertension, like most of the times we start wondering, you know, this pH is out of proportion, put them to CPAT. And this kind of abnormal response, which is stroke volume, gas exchange, and ventilatory equivalents. You can see that the ventilatory equivalent for oxygen, that never decreased actually. So it does show that there is a gas exchange primarily because of the poor response coming from the pulmonary vascular disease in this patient. So this is pulmonary vascular disease. So you can get all these kind of patterns, but by and large, there are just 6 patterns which are these 6 cases have been given, or 7 cases. Anirudh is the one with the neuromuscular diseases, and it's the same guy whom we discussed in the lung volumes and everything. So that is a guy who was put to see that his breathlessness has got more elements, particularly cardiac, so that we can actually go ahead with the cardiac evaluations and pulmonary hypertension. So he has pulmonary hypertension, you can check and look at it. So since my time is over, I would like to stop here. Maybe this was not a thorough teaching on cardiopulmonary exercise testing, like learning and interpretation and other things. But interpretation comes when you start doing it. So once you start doing it, and you have an opportunity to see Dr. Mateen is doing it, now Nagarjuna is doing it. I can see Vishwanathan always is asking me when to start now. He has to start it. So Hyderabad will have these centers to do it. And I am pretty sure that from the days when me and Randeep were doing our DMs, we were really very, very excited to see such kind of things happening, but they were mostly in the cardiopulmonary was in the cardiology departments, never with our departments, and to do these patients on our patients itself was a very difficult thing. So our first CPAT machine came in 2007, and now we have a second one which has come in 2020. So we have 2 CPAT machines which are working now. And you can imagine that any patient who has a dyspnea of unknown origin has to be evaluated by a CPAT. What's the problem? Yes, I think Dr. Mateen brought this point that you can have a catastrophe there. He has given a number 1%. Dr. Mateen, sorry to say that, 1% is a very big number. It's actually 0.5% of the cases, and that data is from the lab in Canada, which is performing on a cardiac patients. We are not performing on a cardiac patients. That's the important thing. I never would like to say ever, but I always say touch wood. We never had any catastrophe. We have maybe 10,000 CPATs done, but we never had it. But yes, if we have doubt, sometimes, I think this is a tip for you people. If sometimes, you know, my consultant comes and says, sir, I am feeling that this patient might have some problem, cardiac, during the CPAT. I said, send him to TMT. Let him do the TMT. If he is able to pass the TMT, he'll be able to do hair also. What's the big deal? So we send them to TMT first and then get it done. Because even if you send them to cardiologists, they will also say nothing, whether there is a cardiac problem or not, unless and until angio is done. So TMT is one thing which you can do prior to, if you are really worried and you are a new setup where you don't want a catastrophe to come. All guidelines required a resuscitation tray to be available next to this CPAT machine. And that is there. I have seen today, he has already made everything A-class in that, which is fit to start and fit to function and fit to learn and fit to teach and fit to benefit the patients. Thank you very much.
Thank you, Dr. Talwar. I think it was an excellent, lucid presentation. You were completely involved. You just peeled the banana and gave to everyone. In fact, interpreting the CPET is a nightmare for me. At least I am benefited today with your excellent presentation with case scenarios. I think I hope the entire audience also is benefited. If there are any one or two questions, we can take. Any questions? You are allowing organizing? Yeah. Yeah.
I think people are too tired for the questions.
Yeah.
So before we break for lunch, just 1 to 2 minutes. So after the lunch, we will assemble in the second floor. So I would request everyone to take the lifts. There are, I think, 6 lifts now. You can choose whichever lift you want. Come to the second floor where the pulmonology department is there and where we have our PFT lab. So we have set up the 5 workstations there. So just like yesterday, as per the numbers on your delegate cards, I would want group 1 to go to the station 1, 2, 3, 4 and 5. So every 20-25 minutes, we will again go in a clockwise fashion. So because we won't be coming back to the hall, so I think I will also take this opportunity to, yes.
Okay. I will give it to the mic last. I think we have come to the lecture sessions. I think you have a hands-on workshops after the lunch. Of course, before lunch, we had a good exercise, CPET. I take this opportunity to thank Dr. Nagarjuna Maturu for making this a big full. I request all of you to give a big round of applause for Nagarjuna's entire team of Yashoda Hospitals for doing this wonderful PFT Summit. I think he has done plural summit before and so many summits. Hyderabad is a venue for so many summits. And also use this opportunity to promote one thing, that is the NAPCON Hyderabad. This NAPCON Hyderabad is going to happen from December 1st to 3rd and November 30th. There are 16 workshops. Yesterday, we had a wonderful scientific committee meeting chaired by none other than Professor Randeep Guleria. I think with the face of our fight against COVID, under his able chairmanship of the scientific committee, we have a lot of things what you are expecting. I think we have got some information what the audience expect, particularly young upcoming pulmonologists. I've seen a lot of postgraduates, DM postgraduates from Orissa and all those people. I think it is going to be a lively conference in lifetime for you, and it is going to be the benchmark. I invite you on behalf of the organizing committee to come to Hyderabad, enjoy the hospitality as well as the academic feast of the NAPCON 2023. And the registration also this time, they were those postgraduates who are presenting papers, I think you start sending from tomorrow. Those first 100 papers which we have received will be given some waiver on the registration or something. We are going to get this and we are going to communicate this. So come and attend in large numbers, make it very successful. When you have seen one institute is doing such a mega show, almost the entire, there are 15 institutes together with so you can see the show. I think everybody should be eagerly awaiting for that show in the December. And Hyderabad is going to rock the show, and with all your support, and definitely will attend the NAPCON 2023. And there are a lot of, instead of didactic lectures, we have pro-con debates, multidisciplinary MD discussions, panel discussions, journal clubs, problem-based case discussions. There are a lot of things you see, new things in NAPCON 2023, and only you will know and enjoy if you come to Hyderabad and witness and be a part of NAPCON 2023. Thank you.
Thank you so much, sir. So one last minute, I would like to sincerely thank all the faculty, the senior faculty who have come, spent 2 days from their busy schedule. I'm very sure that it is not easy to have such eminent personalities talking. Yesterday also, all the sessions were amazing. Today also, it was very good. I have learned a lot. I'm sure every one of us have learned from all the speakers. So huge thanks to all the speakers. Then to all the delegates also, I'm very happy that people are there from the first session till the last session. So that indicates the interest which you all have. So sincere thanks to all the delegates for coming and making this event a success. Also next is very important to thank the administration, because I don't think any event is possible without the support of the administration, and we're lucky to have a good administration who supports such educative initiatives. And behind the show, there is a lot of groups which work. So we have a huge team of branding, marketing, audiovisuals who have been working the last 2 to 4 weeks to make this event the way it is. Then last but not the least is our own team. So as you must have seen our team people already. So we have Pratip, Chetan, and all of them who are sitting here. So I think each and everyone has put in effort to make the show the way it has been today. Then the companies. So we have Schiller and Wyatt who have given their equipment support, on which you have done all the tests. Also we have support from Pharma. The Sun and the Cipla have supported this event. So no event is possible without the support of all the companies. A huge thanks to all of them. I think with this we will break for the lunch, and we will assemble at 3 o'clock. So we have 45 minutes time. So the earlier we come to the workstations, the more time you can spend at the workstations. So I would request everyone to have a quick lunch and then meet at 3 o'clock in the second floor. Thank you so much.